Recording in progress.
Good morning, honorable members. We will be logging in the next 30 seconds. Please just get closer to your gadgets. We'll start the meeting shortly. Right. We are starting now. Good morning, honorable members, and good morning to the team that has come in. I think we are starting with the Council for Medical Schemes now, unless I'm guided differently. Thank you very much for those who have logged in. And may I, as I start, honorable members, just check with Ms. Machalamba, members who are in this portfolio committee that have logged in. Over to you, Ms. Machalamba.
Good morning and thank you, Chair. Present is Dr. Lomo, Ms. Kego, Ms. Sene, Ms. Clark, Dr. Leroux, Mr. Mutubazi, Dr. Tembekwayo, Mr. Van Staden, and Dr. Litlape. I haven't received any apologies. Thank you, Chair.
Thank you very much. Moshomo's iPad or iPhone. Honorable Mutubazi, you will have a challenge to change your phone, or you don't. If you do, that would be great, so that you can always recognize and remember that Moshomo's iPhone is yourself. Honorable members, maybe just as we start, a moment of reflections and the silence amongst all of us, if we can. Thank you. Okay, thank you very much. Let me then start by thanking you all, honorable members, who were here yesterday and who logged in. And then we really thank you very much for doing what you did. My icon is still changing, written wrongly there, but I'll change it during the day. We thank you very much for logging in yesterday and the support that you gave us in really doing what you did. And we hope that today we continue with our very a fruitful discussion and engagement to prepare ourselves. Please remember most of the things that you would want to share with the ministers and the deputy ministers on Friday or tomorrow evening, as there were very important issues that came in from our meetings yesterday. And we thank you very much for your constructive engagements yesterday. Today, we are also having a long day, starting, I think, Ms. Macharamba with the Council for Medical Schemes, followed by SAHPRA, and ending with Office of the Health Standard Compliance and Ombud. If I were then to get that sorted out now, I would appreciate. Thank you very much. Can we get the presenters to come in? And something terribly wrong by wanting to. I should not have allowed you to log in for myself. I must log in and I'll show you the default. I'll show you.
I just did what you told me to do. I didn't do anything else.
No, that's what I'm saying. I should not have allowed you. I should have logged in. Hello? Am I alone here?
We are all here, Chair.
Yeah, I'd ask the members of the Council for Medical Schemes to then log in and then start presenting. I'll tell you what happened here.
Good morning, Chairperson and committee members. My name is Mfana Maswanganyi, the Acting Registrar for Council for Medical Schemes. I'm accompanied by the Chairperson, Dr. Thandima Biba, who is going to start with the presentation. I'll wait for an indication if she's ready, Chairperson.
The members of the Council for Medical Schemes, you are actually taking your time by not starting your presentation.
The Honorable Chairperson, I trust you can hear me. Good morning, colleagues. Can you hear me?
Yes, we can. I can certainly.
Thank you so kindly. Chairperson of the Portfolio on Health, the Honorable Dr. Sibongiseni Dlomo, the Honorable Minister of Health, Dr. Aaron Motsoaledi, and the Deputy Minister, Dr. Joe Padle, in their absentia, the esteemed Portfolio Committee members, Deputy Directors and the Director of the Department of Health in their absentia, the Deputy Chair of Council, the Acting Registrar, Mr. Maswanganye, and his executive. Ladies and gentlemen, I greet you all. We are honored to address the committee today on behalf of the Council for Medical Schemes. Firstly, would like to extend our gratitude to the chairperson and the committee for affording us this opportunity to engage on critical health issues affecting our nation. Your dedication to improving healthcare in South Africa is truly commendable. I am going to request a projection of my slides. I'm not sure if they are indeed projected. CE, could you kindly confirm that my screen doesn't show anything? Mr. Maswanganye?
Chairperson, I've projected. I'm not sure if you can see it from your side.
I can see on my side. Can you see me on the screen?
Yes.
And can other committee members see the projected slide?
Chair, I'm afraid I can not see the slides. I can see the presenter, but not the slides.
Certainly. Will you kindly get assistance in terms of the presentation, lighting the presentation? Thank you so kindly. Honorable Chair, you may project. Yes, kindly so. Thank you so much. Honorable Chair and committee members, kindly meet our council members. Members of the council represent a variety of skills and backgrounds and include experts in law, finance, medical sciences, actuarial sciences, economics, corporate governance, and consumer affairs. On the next slide, we will see the executive team of the Council for Medical Scheme, which is led by the acting CE and registrar, Mr. Maswanganye. Our legislative mandate flows from the Constitution, particularly Section 27 of the Constitution, which underscores the importance of ensuring access to healthcare services for all citizens. Importantly, Honorable Chair, is the Medical Schemes Act, which affords the Council a number of statutory objectives, including in the main protecting the interests of the members and beneficiaries of the medical schemes, monitoring the solvency and financial soundness of the medical schemes.
Dr. Mabeba, can you
Yes.
ask someone to assist you that you project? I don't know whether it's only on my side. You project one slide at a time. Is it possible, or is it only on my laptop, honorable members, that we see two slides at a given time?
We also see it like that, Chair.
My view is the main slide is the one that I'm talking to. And the
Yeah, we-
next slide is the next slide that I will be talking to.
Don't
So
want to see
perhaps
the
if the honorable committee members could focus on the big slide.
No.
Now it's
I
complicated.
noticed, Dr. Mabeba, you joined this meeting very, very early, and these things should have been logistically sorted because you were very early into the meeting. Somebody should have assisted you. We don't want to see two slides at a given time, one slide at a time. Someone must go on a slideshow and really do that. Those were logistics things that should have been done prior to us getting this meeting sorted out. Yes,
Okay, let me do
that
this.
is what must happen, please. No, go back to what you were, not.
Okay.
Honorable Chairperson noted, kindly assist CE and your ICT. The main slide.
Leave it like that now. Leave it like that. Please don't change it.
Thank you
What-
so kindly, Honorable Chairperson. You may proceed to the legislative mandate. Thank you so much. Importantly, Honorable Chair, in the Medical Schemes is the Medical Schemes Act, which affords the Council a number of statutory objectives, including in the main, protecting the interest of the members and beneficiaries of the medical schemes, monitoring the solvency and financial soundness of the medical schemes. Additionally, the Council controls and coordinates the functioning of the medical schemes in a manner that is complementary with the national health policy. Furthermore, the Council's function is to make rules that are in line with the Medical Schemes Act with regard to its own functions and powers. And most importantly, Honorable Chair, Council makes recommendations to the Minister of Health on criteria for the measurement of quality and outcomes of the relevant health services provided for by the medical schemes. Our vision, honorable committees, the next slide kindly so, is to evolve into an agile and transformative regulatory body that fosters affordable and easily accessible healthcare coverage for all. The regulatory philosophy, the next slide kindly. The regulatory philosophy of the entity is guided by the principles of beneficiary centricity, which prioritize the needs and interests of the medical schemes members, while promoting transparency, fairness, and equity in the health care sector. The next slide, kindly. CMS continues to demonstrate its dedication to regulating the medical scheme industry effectively, prioritizing members' interest and driving improvements. In the 2023-24 financial year, CMS obtained an unqualified audit with no material adjustments on the annual financial statements and the annual performance information. The 2023-24 audit outcome indicates significant improvements compared to prior years, where only one finding stood between us and the clean audit. The Council, Honorable Chair, remains committed to achieving a clean audit. Furthermore, CMS achieved 86% overall organizational performance, exceeding the set target of 80%. And with regard to strategic objectives, the entity successfully met 58 out of 59 annual performance indicators, which demonstrates a 98% success rate. And worth noting, the historic backlog of complaints has been cleared, and most complaints are resolved within 120 days, calendar days. The entity managed to resolve 93.95% of complaints aged beyond turnaround time through an effective backlog reduction strategy. These highlights, Honorable Chair, showcase the CMS commitment to financial accountability and transparency, operational efficiency, strategic goal achievement, as well as enhanced stakeholder satisfaction. The CMS oversees a dynamic industry catering to approximately 904 million lives enrolled in 71 medical schemes. Beyond medical schemes, the regulator also accredits managed care companies, brokers, and administrators. As from the 20th of March, 2024, there were 34 administrators, 42 managed care organizations, 2,193 broker organizations, and 7,718 individual brokers operating within the sector, with the last three showing a notable increase from the previous number. Financially, the industry demonstrated robustness, collecting 233 billion in revenue and dispersing 198 billion in claim payments, with a solvency rate of 47.21%. The industry maintains a healthy financial position. Moreover, despite the financial stability, members continue to incur about 40 billion in out-of-pocket payment. The next slide, kindly, so. Regulatory overview, previous slide. It is worth noting the pivotal role CMS plays in regulating South Africa's medical schemes industry, overseeing a massive 200 billion industry with an operation budget of 235 million. The Council for Medical Scheme relies on levies for operations with 6% funding coming from the National Department of Health.
Dr. Mabeba,
Yes, Chair.
you will not finish your presentation if you are going to go on line by line on a presentation that was already forwarded to us. We have read your presentation. Now you cannot go line by line and hope to finish within 40 minutes of your allocated time. You cannot.
Noted, Honorable Chairperson. I will talk to the leadership transition. The Council faces a new trial of stabilization or stabilizing the organism in the wake of the change in leadership with the retirement of the Chief Executive and Registrar. And concurrently, Council has begun crafting a new strategic plan that articulates the Council for Medical Schemes' future for the 2025-2030 fiscal years. These two factors will shift the way the organization operates to some extent, and still by harnessing our collective drive, resilience, and teamwork, we will create a stronger organization aligned with our vision. Chairperson, I would wish to move to the next slide, if that is the case. And when scrutinizing the regulatory challenges, insufficient levy collection to meet the regulatory demands impacts CMS' ability to effectively oversee the industry. The entity continues to face ICT challenges due to inadequate ICT infrastructure, requiring additional funding to enhance regulatory efficiency and effectiveness. And an ongoing need for harmonization of the twin plague model is critical. We also note the issue surrounding the LCPO report that was delivered to the minister in the previous year in November, and we await the minister's guidance in terms of the LCPO. These challenges, Honorable Chair, underscores the complexity of the healthcare landscape in South Africa and the CMS critical role in navigating these issues. In conclusion, Chairperson and the esteemed committee members, the Council for Medical Schemes is steadfast in ensuring that it delivers its statutory mandate through effective and ethical leadership. And I thank you so much. I will allow the CE to take over. Thank you so much.
Thank you, Chairperson of the Portfolio Committee. Thank you, Chairperson of Council for Medical Schemes, and good morning to honorable members and my colleagues who are here. The performance of the organization in the current MTF, starting from the year 2020-2021, as indicated on the slide, you will see that the organization has been performing very well, meeting its target over the years. And this being the fourth year, 2023-2024, we have, as the chairperson alluded to, that we have achieved our targets. We have achieved our targets or exceeded them, managing to achieve 87.93 over the target of 80%. We have also included there a graph showing our performance with regard to Q1 of 2024-2025, just to give an indication of where we are going. This is a breakdown overview of the performance in line with the program that we have within CMS. The first program being the Office of the Registrar, as you would see in the first column there, we indicating the number of planned indicators, the number of applicable indicators, and the indicators that we achieved. You will see that throughout the programs, we have managed to achieve the targets that were intended, except for sub-program 1.5, where we've missed 2 targets, and program 3, where we've missed 4 targets, bringing the total number of underperformance to 7, as it's also indicated under this table. The first output indicator that we've missed relates to the review and development, the implementing a funding model. Chairperson, you would remember that we did report to the Portfolio Committee that there is a need for the organization to review its funding model. We were not able to do this within the year, given the fact that we rely on cooperation with the department and other stakeholders for assistance. So we are still waiting for assistance in this regard. Percentage of stakeholder awareness of the CMS resulting from the survey, we had hoped that when we do our surveys, we will achieve at least 65%, but we only managed to achieve 45%. So we've missed that target as well. Completing meeting packs to be circulated at least 7 days before the meeting. This we're referring to packs that are supposed to go to council meetings, and we have set ourselves a target of at least achieving 30% there. We've also missed this target. We've not been able to attain or stick to the number of days that are set. The output indicator relating to percentage of interim rule amendments processed within 14 working days of receipt of all information. We have also missed this one. We have realized that maybe our target was not so smart in the sense that the number of days that were allocated would have not been enough And we have since worked on changing this target to at least 30 days. Percentage of all commissioned inspections finalized within 12 months from the date of the appointment letter. We've also missed this target. We had hoped to achieve at least 60. There was an investigation that was conducted from our side and completed, but for it to reach finality, we relied on the scheme that was being investigated to give us comments so that we can finalize it. But we were not able to obtain those comments from the scheme. And as a result, there was a delay in finalizing it, but we have since finalized that investigation. The number of schemes member meetings attended, we targeted to attend 44 AGMs to observe, but we only managed to attend 40 because at this time we had a strike in the organization, and as a result, some of the meetings were not attended. And a number of quarterly financial return reports published, we had targeted 3, but we couldn't reach the target here again because we've been experiencing serious challenges with our IT systems that couldn't allow the schemes to submit the information that was required. This is just to indicate the number of programs that we have, sub-programs that we have within the organizations. These are sub-programs that are supporting the core programs. So basically they provide the necessary support to the programs that are supposed to do the core work, and start with the Office of the Registrar, Office of the Chief Financial Officer, Information Communication, which is ICT, Corporate Services, and Council Secretariat. Chairperson, as you would have noted, we have about 58 output indicators that we had to meet. So I do not intend to go through them line by line, except to say that we have already indicated that we've underperformed in 6 of them, but we have overperformed in 23 of them. And we provide the explanations that are indicated in green to explain why we've overachieved. The relevant column here is this one, where it says actual achievement 2023-2024, which shows what has been achieved against what was targeted as the planned annual target 2023-2024. So the green square here indicates that performance has been positive. There was an overachievement, and the red square will indicate that there was an underachievement in that area. So I'm not going to go through all of this. Under subprogram 1.2, there was no overachievement, but under program 1.1, we have one area of overachievement. Under program 1.3, which is ICT, we had 2 areas of overachievement, and under subprogram 1.4, which is corporate services, we had 5 areas of overachievement. And under regulation division, we had 4 areas of overachievement, as they are indicated there in green. Under policy and research, we've achieved our targets, but there was no overachievement under this area. And lastly, under program 5, which is member protection, we had 9 areas of overachievement, and we provide explanations in green there as to why we overachieved. And taking a look at our workforce, we currently have a total of 140 employees in the organization. And this is the breakdown of the number of employees in terms of gender and race. You would see, for an example, on top management, as of 31 March, we had 5 male executives and 2 female executives, bringing the total to 8. However, one should hasten to indicate that this situation has since changed, as you would have seen from the slide that Dr. Mabiba, the chairperson of the council, presented, that we currently have 3 female and 3 male executive members. So currently this situation looks different. Also on senior management, we have 3 male African and we have 2 female Africans. and we have 2 white senior managers as well, bringing the total to 9. I'm not going to go through all of those, just indicating how the information should be read and interpreted. People living with disability, Chairperson, we currently have 4, 1 African male and 2 African female and 1 white female, bringing the total to 4. The turnover trend analysis, we're indicating here that the industry norm stands at 15%, but in the organization over the past 4 years, you see that it's been below the norm, which is 15%. In 2020, 2021, it was at 13.79%. In 2021, 2022 at 9.52%. And 2022, 2023, it was at 14.23%. And in the current year that we're reporting on, it's standing at 10.48%. The terminations that we have had in the organizations, also we break them down in terms of gender and race. You would see that we have had 38.46% of African males terminating their services in the year, followed by 61.5 African females, bringing the total to 100%. Non-permanent employees, also the grand total is indicated as 100, broken down into 38.46% of males, African males, and 61.54% of African females. Chair, with your permission, I will now hand over to the CFO to do the financial statement and audit outcomes. Thank you very much.
Okay. Thank you very much, Registrar. Good morning, honorable members, honorable Chair, all protocol observed. So I'll be taking you through the audit outcomes and the annual financial statements for the year under review. So as the Chairperson of Council had stated, in terms of our audit outcome, we received an unqualified audit outcome for this year. It has improved since the previous financial year. We've battled with a number of compliance issues in previous years of CMS. However, this year we've been able to reduce those to only 1 matter that we still need to resolve relating to consequence management. That will move us from an unqualified audit opinion to a clean audit opinion. That's the area that we're placing a whole lot of focus on as the council to ensure that we move to a clean audit. And following moving to a clean audit, we are able to sustain that throughout as the organization. As stated before, there were no material findings on the financial information that was presented, as well with our performance information. It was found to be useful and reliable. If we can move to the next slide, Registrar. Now, moving to the figures, talking to the financial position of CMS. When it comes to our solvency position, it's still solid, stable as the same as the previous financial year, where we have our assets making up about 2/3 of our books as CMS. Committee members will see that in the previous financial year, we're sitting at 64% of our books being our assets, which is a good thing. And in this year, we're still sitting more or less the same at 63% of our books representing our assets, meaning that we are able to pay what is due to our stakeholders or our creditors as that falls due. So we are stable financially as an organization. Now, moving to the next slide, looking at our revenue. As CMS, our revenue mostly comprised of levies that we collect from schemes. So we have not had issues when it comes to revenue collection with regards to levies. And every year, our levy increases in terms of the revenue is aligned to your CPI increases. As stated by the Chair of Council, it's difficult for CMS to fully budget in terms of its operations, because we need additional fundings for certain key critical things that we need to deliver on, such as your ICT, for example, such as certain employee benefits and other litigious matters that we need to deal with as CMS. However, in terms of collecting what we planned for the year, we were able to collect what we planned for the year, for the 2023-24 financial year. Majority of that being the levy income that we collect from schemes, which we are heavily dependent on as the organization. Now, moving to the next slide, focusing mainly on our expenditure as CMS, what we spend the money that we receive from scheme members on. So in the, you'd see that both years, 2023 and 2024 financial year, the picture sort of looks the same. When we look at our expenditure, how we split our expenditure amongst major expenditure classes, as a total of our expenditure, you see that staff costs take up a majority of our expenditure as CMS, understanding the kind of organization that we are. We rely heavily on the work that is done by our employees within the CMS. Hence, it takes up a significant portion of our expenditure, and followed by your administrative costs and your operational costs. We will talk more to these costs in the next following slides, focusing mainly on administrative costs, what we spent on operating costs, and what influences the staff cost. But looking at the total expenditure for CMS as it is, how we split our spending, or how we've spent, is more or less the same as a percentage of total expenditure over the two years. Now, moving to our administrative costs, which is the next slide. Administrative costs for CMS comprise 16% of the total expenditure. Right, COE being the first one, that is the highest cost for CMS. Administrative costs follows at 16% of the total expenditure. So administrative costs is mainly the running of the organization, which are our general overheads. What influences our administrative costs is mainly your telecommunication, which are ICT services, and the rental that we pay for the office building that we occupy. Yes, there's been some increase in our telecommunication services for the current financial year that we're reporting on. This is mainly because, as spoken by the chair, that we need to invest more in our ICT. Now we're moving into a phase of digital transformation within CMS. There's more that is required in terms of the ICT and the ICT services. Hence, there's been an increase in terms of our telecommunication expenditure in line with the ICT plans that we have as the organization. Also, another cost driver here where we spent a significant amount of money in administrative costs is the rental for the office building that we occupy, which is a standard amount in terms of the current contract that we have as the organization. Then moving to our operational costs as CMS, the next slide. Operational costs of our total expenditure comprise 13%. And then operational costs, key cost drivers, the legal fees for the organization. That's one of our biggest cost drivers as well. The reason for that is because by virtue of being a regulator, decisions that we make sometimes can be taken to court by some of our stakeholders. We operate in a litigious environment. Hence, there's been a move upwards in our legal fees. As well, there's been some traction on the Section 59 matter. Hence, again, an increase in comparison with the previous year on our legal matters as CMS. Also, for labor-related matters, there were matters that finally appeared in the labor court, where as CMS, we had to get some from legal assistance when we appeared at the labor court to talk to those matters. And lastly, looking at our consulting costs, that's because of the work that we're doing when it comes to the PMB review work, where there's been some increase in the number of work that we've done during the year under audit, amongst other things. And moving to staff costs, which comprise or makes up 68% of our total expenditure that we've incurred as CMS during the year. The next slide, please. For staff costs, the main items that influence for the 2023-24 financial year, the change in the staff costs or the staff costs that we have disclosed on our annual financial statement is a standard cost of living adjustment. There has been an exercise of salary benchmarking that was done by the organization that is in line with our HR policies that we're required to do that in a certain number of years. So the outcome of that and the implementation of the salary benchmarking exercise that was done impacted on what you see as disclosed as the staff cost during the year. And also, as alluded by the acting registrar, we had a strike action in the previous financial year, and there's been an agreement, or there was an agreement with NAHAU that was reached, and the implementation of that agreement as well had an impact on what we have disclosed as the staff cost for the 2023-24 financial year. Now, moving to the matter that stands, the next slide, that stands between CMS and a clean audit, focusing more on irregular expenditure and consequence management. So, as CMS, what we've disclosed as irregular expenditure or irregular expenditure that we incurred in the 2024 financial year has reduced from the previous financial year. Mainly with the 893,000 that we've disclosed relates to an expired contract, which has subsequently been cancelled. Proper procurement processes followed, a new service provider appointed in CMS, and therefore there'll be no irregular expenditure incurred moving forward. And secondly, consequence management, as required by the PFMA, is that where there are cases of irregular expenditure and and wasteful expenditure, there must be a committee that looks into those cases, that performs a determination test, loosely speaking, that performs an investigation to look at that non-compliance, and then followed by consideration for disciplinary processes. For us as CMS, we do have a committee that looks into those matters, the Loss Control Committee, in short, the LCC Committee, in line with what's required by the PFMA. And of the matters that are sitting in our register, irregular expenditure register, the committee has been able to do or to investigate or do a determination test on all matters starting from 2022-23 financial year all through to the 2024-25 financial year. And further, these matters are now sitting with HR, are being considered with HR for disciplinary processes, which are currently underway. And now there are other matters or other cases emanating to prior 2022-23 financial year that the LCC is currently busy looking into, performing a determination test on those old matters. And the plan is that we will need to conclude that investigation before the end of the current financial year, and also having started with the disciplinary where there are individuals that are found to be responsible for the non-compliance that would have been identified. So current is what we're currently focusing on to be able to move us as the organization from an unqualified audit opinion with one consequence management matter to a clean audit opinion. We are confident, Chairperson and honorable members, that we'll be able to achieve this as the organization. Lastly, as just a concluding slide on the financial information for CMS, we acknowledge that there's been a decline in the reported surplus for the year. However, our financial position as the organization remains stable. Our liquidity position also has improved, and we are able to pay our debt as they fall due. Also, our net asset position as well has strengthened to a certain degree. And yet we acknowledge that our financial position has improved on the books. However, there are other key cost pressures that we deal with as the organization that we need to manage, as the chairperson has spoken to, like your ICT infrastructure, some vacant unfunded positions, some employee benefits, and so forth. However, we are working closely with our mother department, the Department of Health, in ensuring that we have a long-term financial sustainability model, which is funding model for ourselves as the organization. That is the last of the financial information slide. Chairperson, I'll hand over to you, Acting Registrar, to conclude. Thank you very much.
Thank you, CFO. Chairperson of the Portfolio Committee, that brings to an end our presentation. And we will now do the discussions as guided by yourself. Thank you.
Okay. Thank you very much. You took all your time and added 2 minutes above your time, which is not bad. Thank you very much for the presentation. Very clear, well structured. And sorry to the chairperson who wanted to really make sure we understand everything. And she was steady, putting one slide at a time. But thanks that you have actually presented. Honorable members, it is your time. Okay, I've seen honorable members in this order who want to engage, starting with Honorable Dr. Tembe Kwayo, followed by Honorable Clark. Number 3, Honorable Dr. Leroux, followed by Honorable Dr. Litape, Honorable Shabangu, and Honorable Van Staden for now. Those are the hands. Okay, there's another one now that's come up, Honorable Sen. You know, honorable members, you just do your bit with the hope that the other 4 that you would have wanted to ask will be asked by other members. If you just stick to your 3 to 4, that would be great. Starting with Honorable Dr. Tembe Kwayo.
Morning, Chairperson, and thanks for the committee's presentation. My first question is based on when they were discussing the 6 indicators missed for achievement of something. And then with there's something where they said there's lack of scheme to commend for a waiting period of 12 months. And that is the reason that led the department on missing some of the achievement indicators, as it was stated. But my question is, I mean, you wait for comments for a period of 12 months, and then you come and report it to us to say we were waiting for the comments for 12 months. 12 months, it's a very long waiting period for you to wait for the comments. How do you intend to revise this turnaround period of receiving the comments in order so that you can complete your indicators? There was mention of the fact that the ICT has a challenge because it requires additional funding. And I just would like to find out, as you have mentioned that ICT require additional funds and it's a challenge, how does it affect the full capacitation of your ICT department? The last one is based on the irregular expenditure. Yes, they gave reasons under irregular expenditure and what is it that they're doing. But I mean, it's not fair. The reasons that they gave for this irregular expenditure, it's not sufficient. It's not even convincing for us, especially on how they are going to address this problem as it was identified yesterday by the AG. We need more reasons that can convince us that there will never be a repetition of irregular expenditure in your department. Thank you, Chair.
Honorable Clark.
Thank you, Chairperson. And Dr. Tembe Kwayo has covered my question in terms of irregular expenditure, so I'm not going to repeat that. Then regarding the CMS's participation on the NHI Technical Working Group Committee, what is the update on this regard? And then which disciplinary matters are being dealt with at the CCMA? The CMS is concerned about exorbitant amounts spent on unnecessary litigation and what plans are going to be put in place to mitigate this challenge. Then in the financial year under review, the CMS found instances of non-compliance with Medical Schemes Act regulation where medical schemes fund PMBs from members' personal savings accounts. I mean, this is highly irregular and illegal. So what steps has the CMS taken to prevent that? And then just to ask, you know, in terms of the health market inquiry recommendations, there's a huge push around those recommendations to ensure that affordable medical packages are put in place in line with people's affordability in order to give them quality healthcare as they can afford in terms of their income. You know, what is the CMS's strategy in dealing with this? Thank you very much.
Honorable Dr. Leroux.
Thank you, Chair. Chair, I just wanted to ask some questions. Well, firstly, thank you very much for the presentation. And I think I just want to say, commend the report and the way it was done. Also, very helpful to I think it's very upfront and commendable to show us upfront where you've come short on those 6 indicators. So that's very, we appreciate that, or even though we might criticize you about falling short, it's great to see that upfront. That's a very kind of transparent way of presenting. So thank you for doing that. And I think my major concern is just looking at the increases in costs that have gone in the budget from the last financial year to this financial year. And just to say, I've been looking at the report that was given to us, not just this presentation, but looking at the report where salary costs have, and actually we're looking at the report's response and looking at the raw numbers, the salary costs have actually gone up by 18.9%, the operating expenses have gone up by 30%, and the administrative costs by 29%. And that is quite a significant increase over a year. We have had explanation around the operating expenses, particularly around the issue of litigation, but an 18.9% increase in staff costs is significant, and also a 29% increase in administrative costs is also quite significant. And if that could just be explained where those costs have gone. I am also kind of quite flabbergasted at the staff expenses. The staff expenses are 122 million rands. There are 57 staff members. That means that on average, staff are earning 2 million rands per staff member. That is pretty extraordinary. And I would like to get a sense of what the top staff members are earning, the CEO and the registrar. I know you said that you benchmark that against, the industry, but that seems to be a very, very high and quite, it's interesting that there would be a strike for increased pay when the pay bill is so high. And I just wanted to get a sense of what that cost of living adjustment was that was made, because we can't just pay people whatever we want. We have to actually do this in a reasonable way. And this is, after all, an institution which needs to look after those things as well. So if I could get some feedback on that, please.
Thank you very much, Honorable Dr. Leroux.
Thank you, Chair. The questions that I have is one, in relation to labor matters, which would follow up on what Dr. Leroux was asking. You've overachieved on some goals. Can you expand on what are the challenges on your labor matters and things that are in the courts? And I've heard from staff members that there's an issue about payment of performance bonuses. Can you give us the link between your overachieving and not paying performance bonuses that are being claimed by staff members? And lastly, what role do you see for CMS in the future health dispensation of the country in relation to NHI? Whether it would be contracted, expanded, progressive, or visionary? What are the things that we could help you with? What value do you think you could add to the proposed future of healthcare in the country? Thank you, Chair.
Thank you, sir. Honorable Shabangu.
Thank you, Chairperson. Partially covered, but let me just take 2. And thank you for letters. Also appreciate the report that has been presented to us in a summary, but we had detailed report in our midst. According to the AG's report, the CMS has not implemented consequence management based on the non-compliance on the PFM, as the other members has alluded to. So the implementation of consequence management was not done on that irregular expenditure that was incurred in the prior years. And that there is also inadequate audit action plan to ensure that issues emanating from prior years are dealt with before the audit process. What are the challenges that the CMS encounter which impacts on its ability to address those issues? The second one will be, how many of the received complaints raise the recurring issues? And what are the issues raised, and what mechanism in place to prevent the reoccurring of the complaints? If there are any interventions, how are they projected to reduce the number of complaints received? I will pause there, Chair. Thank you.
Honorable Van Staden, thank you.
Good morning, Chairperson, colleagues, and people presenting to us. Yeah, I see I'm last in line now. I've been covered mostly by all my colleagues before me this morning, so I'm a bit slow. But I just want to know, can we please get an update on the restructuring process that was being implemented at the Council of Medical Schemes? Thank you, Chair.
Thank you, sir. Honorable Sene.
Thank you very much, Chairperson. Good morning to members and everyone in the platform. Chair, let me also join honorable members in welcoming and appreciating the report as presented. My first question, Chair, I want to know in what ways does the CMS ensure that prescribed minimum benefits remain relevant and also responsive to evolving healthcare needs? And then my second question, Chair, is the presentation notes that additional funds are actually required for the ICT challenges. So what specific IT challenges is CMS facing, and what impact do they have, and what is the specific projected amount required to resolve these issues? And then, Chair, what funding strategies are being explored to close this finance gap of CMS? Thank you very much, Chair.
Yeah. Thank you very much, honorable members. Maybe the leadership of CMS can also assist my understanding on the following. You raised in your presentation that 40 billion, I probably hope is per annum, is out of pocket payment. Now, you actually have to assist me to understand the measurement. I would imagine I'm Dr. Dlomo, medical aid, bonitas, or whatever, and then I get to be processed. I have that deducted and it services me. And then just guide me to see how you actually quantify this out-of-pocket payment. Where do you get the numbers? How to pick it up? Maybe it's members who have been declined by the medical aids that they are members of. Just this understanding, and also this figure to be very huge. In the previous association, when your presentation to the portfolio committee, you alluded to how you would be working and wanting to be part and supporting the universal health coverage and visage in the country in terms of NHI. Now, how is CMS preparing for this phase implementation of NHI? And what role does it anticipate to play in addressing any potential challenges that may arise in the medical scheme sector during this transition? You may probably be picking up that there may be some regulatory challenges that might come with that process, maybe that you have already been thinking of. It would be very important to have an understanding of that part. And members have also asked, I would also like to know more about this composition of employees up to 70%. And a very strong question of Honorable Thembekwayo, Dr. Thembekwayo, of the percentage of commissioned inspections finalized within 12 months, that you had put a very high bar of 60%, but your achievement was 0. Assist us, CMS leadership, with the responses to these questions. Thank you very much.
Thank you, Chairperson. I will take some of the questions and then ask my colleagues to take some of them. Perhaps I should start with the question relating to commissioned inspections. What we are saying is that commission inspections are supposed to be completed within 12 months. So if somebody gives us allegations today and we initiate an investigation today, we've set ourselves 12 months to complete that investigation. We're not saying that we're giving the scheme 12 months to comment. So the period within which a scheme should comment, it will normally be 30 days, but the schemes will request for an extension because of the nature of the findings that might be in that report that they have to respond to, or sometimes they would say they need to brief their lawyers to be assisted with in responding to those findings. So the 12 months speaks to the period of completing the investigation, not of submitting comments, Chairperson. The questions relating to irregular expenditure, I will defer those to the CFO. There was a question from Honorable Tembekwa, why want to connect for, yeah, that's for 12 months issue. ICT, how does it affect the full capacity? The ICT systems that we have, the problems is it's very old and it was poorly maintained. Most of it, it's working on apps that were developed internally by people that have left the organization already. When the current staff try to search for sometimes for the architecture of how these apps were built and how they should be fixed when they have issues, it's difficult to even find those documents that should assist in maintaining or fixing the issues as and when they arise. We also find that some of the systems that we're supposed to be purchasing to support this infrastructure is no longer available from the market because it's based on a very old infrastructure. So that is the issue. And the impact that it has had in our work is that we have not been able to achieve some of our targets. For an example, the collecting and publishing of quarterly information. We were not able to make the platforms, ICT platforms for the schemes to be able to submit that information and for us to then analyze and publish that information. So this is the impact that the ICT infrastructure is having on our operations, which is very serious. I will ask the CFO when she's respond to the issues of cost to also touch on how much this will cost to put together a new ICT infrastructure altogether. Honorable Clerk, on NHI and update, I will ask in particular my colleague, Dr. Michael Willie, to deal with this so he can just note it for now. And the plans to mitigate legal costs. What the Act does is that it says anybody who is not happy with the decision that is made by the registrar, they can appeal that decision internally in the appeals committee, and if they are not happy, they can take it to the appeals board. We try by all means that matters that are dealt with within these structures, which are internal, we use our internal resources to defend those matters. It's only when matters have to go externally where we would, in most cases, try to involve external legal assistance, unless the matter is so complicated and we are of the view that its resolution should serve as a precedent for other matters, then that we can include external legal assistance even in these internal forums. But the general principle is that internal forums, we're using our internal legal staff members. And we've also tried to when we have these legal challenges, to reach out to the other parties and see if it's not possible to resolve the issues amicably before they can be escalated to the courts where the cost might be very high. steps taken to prevent schemes from paying from abusing PMBs or paying PMBs from day-to-day member savings. What we do here is we conduct what we call on-site inspections. And these on-site inspections allows us or assist us to detect where there could be irregularities in terms of how schemes pay claims. We also, within our research unit, also monitor some of this information when we have collected it and analyze it to see what has been the pattern in particular schemes. There was a case that we did, I think in the past 3 years, through the research unit, and we found that some administrators indeed, they were using member savings to pay PMBs, and we were able to engage with them directly and issue directives that those funds that were misused in this regard, they have to be repaid to the members and the scheme directly. And there was a question by Dr. Leroux requesting the explanation of cost. I will leave this to the CFO. The question from Dr. Litlape regarding labor matters. The labor matters that we are dealing with currently relate to some of the former executive members that have since left the organization and have challenged the manner in which they have left the organization in different forums, be it the CSCMA, Labor Appeals Court, and the High Court. So we are currently dealing with these matters, but also it's correct that there is an issue with regard to performance bonuses. We have an issue, a dispute currently with the staff members because the performance bonuses that are paid are not in line with what the policy determines in terms of how much should be paid. But the payment is in line with what the organization can afford. And this is where the dispute lies, because staff members would want payment in full. And council has taken a decision that the bonuses can only be paid in line with what the organization can afford, and in particular, the budgetary constraints that we face. And that's basically the gist of it, Honorable Dr. Litlape. CMS in NHI, our stance is that currently the NHI Act carves a particular niche for CMS to continue playing after the full implementation of the NHI. And that it says medical scheme will continue to offer complementary services. And that means those medical schemes will need to be regulated, and it will be the responsibility of CMS to ensure that those schemes continue to be regulated. So by and large, this is the role that we will continue to play. But I will also allow Dr. Mabiba, the chairperson of council, to add on this matter if she has other information that she wishes to add on this chairperson. There was also a question from Honorable Shabangu with regard to the AG report, CMS not implementing a consequence management. I will leave this to the CFO. She has already explained when she was doing the presentation that consequence management requires, it's a process. And she has explained that in the current loss control committee, there have been processes that have been undertaken to investigate the irregular expenditure, to make a determination, and then make a recommendation to HR, which is then supposed to take action with regard to consequence management. And at this point, this is where we are with certain matters. However, she did indicate as well that there are matters that are coming from prior to 2022 period, which matters still have to be investigated, and we are in the process of dealing with those matters in following the same steps as well. But I'll allow her to perhaps expand on this point as well. And Honorable Van Staden requested an update on there was a request for an update on, okay, I can't see what I've had there, but I hope some of my colleagues would have noted this point. And there was a question from Honorable Sani on PMB review to ensure that they remain relevant and respond to the needs. I will ask my colleague again here, Dr. Willie, to give an indication of the processes that we've been engaged on to try and ensure that the PMBs are in line indeed with the needs and the current burden of disease in the country. And there was a question relating to what are specific challenges with ICT and what impact do they have. I think I've covered this by indicating that the infrastructure is very old. It's very old in the sense that we don't have vendors that are supplying some of the support that we require. It's also old because it was basically designed and constructed internally, and people that have designed it are no longer with the organization, and we're finding it difficult to maintain. And what funding strategies are being employed to close up this gap? Again, I will allow the CFO to touch on this with regard to how much has been allocated to try and close this gap, and on the question of whether or not that is sufficient. Honorable Dr. Dlomo Chikwesen, you've referred to the out-of-pocket and how we have collected this information and how we quantify this. I will allow, again, Dr. Willie to deal with this question, explaining exactly how this information is collected. But just to say that we do recognize that the figure that we put out there, it's a very what you call it, it's not necessarily an accurate figure in that we rely on information that we could collect based on the claims that we have been put through medical schemes. So where members have paid from their pocket and those claims were not processed through and declined through medical schemes, we will not have that information. But Mr. Willie will cover this point. And how is CMS preparing to work within the NHI? I think I've covered this and I've indicated that the chairperson might also want to add if she has more information on this. I've also covered or started with the question with respect to the commission inspection. With your permission, Chairperson, I can ask firstly the chairperson of council if she wishes to cover certain matters that she might have more information.
Registrar, let's go back to you a bit. You said you can't see your handwriting on the question of Honorable Van Staden. Now, can we just get that?
Okay.
We'll come to that one.
Yeah.
Or you want us to?
I've put it in the chat, Chair. It was an update in the restructuring process that was implemented.
Oh, yes. Thank you very much, Chairperson, and thank you, Honorable Van Staden. The restructuring process has been completed. The current structure that we are working on is what we referred to in the past as the restructuring, where you would have seen from the structure that the chairperson presented, it shows that there is full implementation of that structure, except that currently we have a vacancy in the position of the registrar. So the restructuring has been completed. However, we are in the process of reviewing the structure to see how it has been performing since implementation. And once we've done that work, it will then be shared with council, and the outcome, therefore, if they need changes on the structure or some level of tweaking, that will be dealt with. But at the moment, the restructuring has been completed, Chairperson. May I ask the chairperson of the council, Chairperson, if she wishes to add more information to also come in?
Thank you so kindly. Just a quick one for me. In respect of the NHI, indeed, the CMS is committed to being a formidable player in the quest of achieving the universal health coverage. We remain an active participant in the NHI Transitional Working Committee, and the committee will perhaps know that we are in the first phase of the NHI implementation, which started in 2023 to 2026. And the position of CMS is to shepherd the medical schemes industry and support the establishment of frameworks that clarify the extent of complementary cover to services not reimbursable by the NHI fund. So it is an ongoing process, Honorable Chair, and CMS is indeed active in the process. Thank you so kindly, Chair.
Thank you, Dr. Mabiba. Chairperson, with your permission, I would like to ask Dr. Willie to cover some of those points and then followed by the CFO on the issues of cost and consequence management. Thank you.
Good morning.
Just hold on. All members who were on the platform, honorable members, had their chance to ask questions. I see that there's a consistent hand of Dr. Letlape. Either he forgot to send it down or he wants to speak again. I also noticed that Honorable Motubase had no hand then raised, and his hand has now come up. We don't usually do second round on issue. We give members once off, and then we ask, and then we get done and answers. So I don't know the point made by those two hands on the platform. Dr. Letlape?
Thank you, Chair. The point I just wanted to make, and maybe we could, they don't have to answer now, but give us a written answer, is we've had a health market inquiry 2019 report that speaks to the activities of the medical aid industry now and the role of CMS. Can we get from CMS what their position is and what their plans are with respect to the recommendations of the HMI? Because we speak of NHI 5 to 7 years, but what happens with the people that are on medical aid now, given that we have had recommendations from 5 years ago that fall squarely on the mandate of CMS here and now?
Dr. Letlape, again, for time management, we get a presentation to us a day before. We listen to their presentations right here. We formulate our questions so that you get a once-off chance. We don't have a second chance to come back. The principle remains that we will give you a space once off to ask questions. Honorable Motubase, your hand has just come up though. What is the issue there?
No, my apologies. I think I had several questions with difficulties with IT. I'm happy that you can hear me now, and I fully respect your directive. But can I simply ask this question because it's the first time I ask? What is the turnaround time to deal with the IT issues? Thanks, Chair.
What's the turnaround time to deal with?
I mean, they've been mentioning several times, and it worries me that their IT difficulties seem to be taking a lot on them, that people have actually left. And so, what is the turnaround time to fix their IT challenges?
Okay. Registrar Chair, please accommodate these latest clarity-seeking comments if you can. Thank you very much.
Thank you, Chair. With your permission, can I ask that Dr. Willie continue to respond to the questions relating to PMB and NHI, and then we will come to these questions that have just been asked now.
Yeah, good morning, Honorable Chairperson of the committee and esteemed committee members, all protocol observed. Thank you for the opportunity. So it's about 3 areas that I want to cover. Let me start with the first one on the out-of-pocket payments. Chairperson, the figure we report on of about 40 billion rand we collected through the statutory returns information that we get from medical schemes. So the source of that information is purely from schemes themselves. But the way we compute it, it's a proxy measure where we calculate the difference between what was claimed by the medical service provider and what was eventually paid by the medical scheme, right? And then that difference then becomes what we compute as an out-of-pocket payment. And in our computation, we also take into account the personal medical savings account. So it is a sore issue because it's a growing trend. And then the other issue is that it's a function of a number of things. Maybe before I get to that, it's understated in a sense that sometimes members of medical schemes, when they go to a pharmacy, sometimes they don't always report some of those funds to the medical schemes itself. So even the 40 billion rand that we see there, it's currently understated. But what we want to underscore is that it is actually indeed a proxy measure, so that at least we give an indicative figure of what the levels are. So that is the first part. But it's a function of a number of things. For instance, it's a function of a benefit design for the medical scheme, and then also the benefit design or benefit options, they differ in terms of the richness. So we anticipate members who are on your lower end benefit options to be exposed to out-of-pocket payment because in nature it's not rich, purely because of the premium that is paid. Similarly, even your higher end options, they sometimes do attract out-of-pocket payment. This could be a number of other issues such as the use of DSPs and so on. So it's a multifold. Like the registrar was indicating, that we do monitor this so that at least we engage with medical schemes who identify as outliers. And also currently we're busy with the research study that is closely looking at this, trying to assess some of the key drivers. So that's the first point on the out-of-pocket payment. And then the one on the national health insurance and how we partner and participate in the NDOH processes. Maybe let me capture that, and also the impact of the NHI on the medical schemes. I'll capture that as one response, right? So what we anticipate certainly is that the shape and form of the landscape insofar as medical schemes are concerned is certainly going to evolve and change. From the operating model point of view, from the contracting point of view, this is now contracting for third-party administrators or services, and also from contracting of medical service providers, that is also going to change. But the biggest effect and impact to the CMS will be the change in membership profile, because that will have an impact on the revenue stream for the entity, and also the sustainability issues. We also do anticipate that some of the provisions in the Medical Schemes Act are certainly going to be affected, I think, which is why then there's an important aspect around the Medical Schemes Amendment Bill, which I think Dr. Likat was indicating, how can the committee assist the CMS? So I think that will be one of the key priority areas that certainly CMS will working closely with the NDOH, approach the committee to ask for some guidance and assistance so that at least we are able to amend the Medical Schemes Act in alliance with the NHI. But the golden opportunity that we see and we optimize as the CMS is the collaboration with the NDOH, because we understand that Section 33 is very critical and important in terms of outlining what certainly would be the role of the CMS. So what we are doing currently, we are participating in the NHI task team. We are working closely with the structure or cluster that is responsible for the benefit package of the NHI, so that at least we try and align with their processes. So that is where we are. And at some point, we're also invited to come and give a presentation on the medical scheme landscape, the performance, as well as the structure. So at least we're active in those processes. So that is one part on the NHI. So that also those processes will be ongoing. Then the last part is on the PMB. How does the CMS ensure that PMBs remain relevant and responsive to the healthcare needs of members? So I think this one is multifold. It's a function of benefit design, right? Because our PMU unit on an annual basis, they review benefit changes within medical schemes. But what we do proactively as the entity, we develop PMB benefit definitions to assist the funding of some of these conditions, especially PMBs, where there are gray areas. And some of this information, we pick it up from the complaints themselves, so that at least we try and alleviate some of these coming back to the entity. So CMS does about 10 benefit definitions a year on key priority areas that we deem to be challenging, so that at least we assist medical schemes to fund these better. But on the other token, we create some level of awareness to the members so that at least they understand and hear what is their benefit entitlement. So that is one. And then we also do CMS scripts by our clinical unit so that at least we empower the members of medical schemes. The other big part, the last part I want to make on PMB, the relevance of PMBs. The benefit structure in medical schemes is hospice-centric. What it does, it doesn't take into account the primary healthcare component. So the current PMB review process itself is currently looking at the PHC component, which is the primary healthcare component, so that at least this becomes part of the PMBs, because PHC is a very important structure of any healthcare system. So we have concluded the costing of the PHC package, currently engaging medical the stakeholders, so that at least from the cost perspective and affordability, at least we're able to measure those and communicate and engage the industry proactively on those. So those are the key three areas that we are currently dealing with, just so that at least we ensure that and then we also want to emphasize PMBs are very important, especially from the financial protection of members, so that we don't expose them to higher levels of out-of-pocket payment, especially those who've got chronic conditions. So those are the key points I wanted to cover, Chair. I think let me stop here for now. Thank you.
Thank you, Dr. Willie. Chairperson, through you, may I ask the CFO to then cover the questions that relating to the cost and irregular expenditure.
Okay, thank you, Registrar. Just to respond to the few questions, just one minor addition to the restructuring question that was asked earlier on. Yes, we are implementing the structure. However, there are certain positions within the structure due to our funding that are not filled because they are not yet funded. Just to give that one point of clarity, to say that not every single position within the current structure that following the restructuring is filled because of funding issues. But now to move to consequence management and the challenges that the LCC or CMS has when it comes to consequence management. The issue with CMS is that we have a significantly large register which of irregular or non-compliance findings dating back to your early 2000s. Sometime there that we need to look into currently. And also we formulated that LCC committee that looks into these matters. However, that committee is made up of internal staff members that also have their other day-to-day work that they need to continue with. And that committee looks at every single transaction that's sitting on our register to perform the determination test or to perform loosely speaking, the investigation into every transaction, what caused, what control breakdowns were there, what caused the irregularity to occur, who was responsible for it, how has CMS improved its controls to ensure that that irregularity does not reoccur. So that committee looks at every single one of those questions in every single one of those transactions. So because of capacity issues, we haven't been able to move with as much speed as we would like to move. And the intervention then that was brought in to get a service provider to support the loss control committee to move quickly with a number of matters to be able to close the determination test and to quickly move to consequence management or to HR to consider disciplinary. Hence, in my report then, we stated that we were able to close matters starting from 2022-23 financial year all through the current financial year. We've been able to investigate all of those cases, and those cases, some have been closed when it comes to disciplinary by HR. There are some that are still in the process of disciplinary of these matters from 2022-23 to date. Now we are sitting with old matters from before 2022-23 that we need to clean out or clear out. So those are the matters that we are currently looking into, that we've received support again to be able to quickly move on those matters for us to be able to hand over to HR to consider a consequence management. So those are the things that we're doing, and those are some of the challenges that we faced when it comes to capacity, and also when it comes to these cases being old matters, and then having to find people to discuss these matters with, to understand what happened, having to find all documentation to do your investigation. So those are some of the complexities that we had to deal with as the loss control committee in quickly moving on these matters. And in terms of, again, irregular expenditure, the controls we've put in place to ensure that matters of non-compliance don't reoccur. Specifically, the matters that we've disclosed here are on contract management. So we have not had any new issues of contract management as the organization. The contract that's being disclosed is an old contract that we've taken through to procurement. We've procured and we've been able to get an appropriate service provider. That control has been closed. So we've been able to clean up a number of old matters where there were long outstanding contracts that have not been renewed appropriately, that have not gone through procurement process. And we keep a contract management register where we just monitor and track contracts that are close to expiry to ensure that we go to a proper procurement process before the expiry of that contract to avoid any possible irregular expenditure. So we've tightened that area there when it comes to contract management to manage these issues not having to reoccur. Hence, you will see there has been a decline over the years when it comes to irregular expenditure incurred by CMS. Now moving to the issue of the variances relating to staff cost, administrative cost, and so forth. Apologies, Honorable Member, if I didn't get your question correctly or the comments you made, where you said we have 57 staff members and our salary bill is sitting too high. We actually have 125 staff members that is disclosed on page 136 of the annual report. So our staff members is 125 staff members, the CMS, not 57 staff members. When it comes to the salaries for executives and so forth, on page 138 of the annual report, you will see on note 24 where it talks to remuneration of management for the top executives. There is a salary structure that's given there, how much each executive is paid annually for the 2024 financial year and for 2023 financial year. And the reason there's been a jump in salaries from the previous year to the current year, most specifically, is the benchmarking exercise. The benchmarking exercise was supposed to be implemented in the 2023 financial year, starting in July 2023. However, the decision or the implementation was only, the decision was only taken in 2024. Therefore, there was some back pay component included in the 145 million that we've disclosed in the 2024 financial year on page 136 of the annual report. So included in there is a back pay relating to 9 months of the 2023 financial year, where the benchmarking was supposed to be implemented or effective from the 1st of July in 2022-23 financial year. Hence, now you see that jump. It's because some of the costs that are there in 2024 actually relate to the 2023 financial year when it comes to that benchmarking exercise. So that's the main key reason sitting there. Yes, there is other reason in terms of that the agreement that CMS agreed and entered into with NEHAU, where we have not, because of our financial difficulties, we have not been able to fully cover all of the employment benefits in terms of our HR policies that are due to staff members. So that has been the key thing. Just to take the committee back a little bit, the committee would recall that CMS has had financial challenges since 2019-20 financial year, where we've been rolling in a deficit, having issues of not being able to pay suppliers, not being able to pay our staff members. That was 1920, and again 2021, we also had those issues. We only finally broke even in 2021-22 financial year as the organization. Hence, you'll see this huge move for us to be able to try to look at a funding model. We have not been able to fully take care of our staff members. We acknowledge that because of the finance issues that we've had. That's why then there was that strike action in the previous financial year. This huge increase in our salaries bill is because CMS is trying then to comply with its policy when it comes to the benefits that are due to the employees. The monies that we have not been paying employees in the previous financial year benefits actually in line with the policy that are required by the employees. Still, as the registrar have said, we have not yet been fully able to take care of everything, such as the bonuses, as one of the honorable member has stated. Because of the affordability, we need to balance amongst a number of things with ICT challenges as well that we're experiencing as the organization, and also being able to fill the other critical positions that we need that are not yet filled and not yet funded within our structure. So there are a number of competing priorities, but we try as far as possible to try and manage all of those. And moving to administrative costs, where there's been a jump there. Critical to administrative costs, the reason why there's a jump, you see the telecommunication costs, which is mainly ICT related. We've spoken to our ICT issues and the need to invest in that. We're trying as far as possible to invest within ICT and some of the other subscriptions that we need and some plugs that are required within ICT. There's also an increase when it comes to training and staff development in us trying to comply with our policy, trying to put our employees first. There's been an increase in staff development cost for our employees to be able to go on training, acquire more skills, obtain and some certain NQF levels, and we have doctors and so forth, people with masters within CMS. We're trying to fund those. Hence, you will see a jump there. You would also see a jump in rental space, which is two reasons why there's that jump. There's an annual increase that's included in there for the 2024 financial year of about 8.5%. As well, in the previous financial year, there was an adjustment that was made when it comes to the rental, a smoothing adjustment. Is difficult to explain, hence the lesser rental in the previous financial year. In the current financial year, there's no smoothing impact using a technical accounting word. It's the core rental that was paid in the current financial year. So it might look a bit distorted as if there's been a significant jump in rental. However, there hasn't been that significant jump. Is per the lease agreement. It's just an accounting matter of how we disclose certain information and how we do certain calculation. So basically, key cost drivers there and the reasons for that jump is our training, is ICT-related telecommunication, is the rental, honorable members. And lastly, just to talk to the funding for IT, I know the CIO will talk to the issues on IT and what's our plan and when do we plan on resolving the ICT issues. For me to talk to the money that's being required for IT, we submitted a proposal when we discussed this matter with Health and we discussed it with the National Treasury. We submitted a proposal where we asked for a period of 4 years cumulatively that we need 55 million for ICT. That 55 million is for 3 specific ICT related positions, which are permanent positions as ICT project manager, an ICT solutions architect, and an ICT governance specialist. That's one, which is a recurring cost. And also we need once-off infrastructure funding for us to be able to resolve the ICT challenges. Also, as part of our rollover request that we've submitted to National Treasury that they're currently looking into, we've also identified some money that we have, and we asked Treasury that we keep that money to fund some of these cost pressures, which is your ICT that we need to quickly deal with, and also other cost pressures within CMS. I think for more contextual view of things, I think the CIO can talk mostly on how then we'll be able to sort out the ICT and during what time period. Thank you, Chairperson.
Thank you, CFO. Chairperson, may I, with your permission, request the CIO to respond to the question of Honorable Mutubat with regard to the turnaround.
Please wrap up now. Please wrap up, really.
Thank you. CIO, quickly.
Thank you, CE, and good morning to the honorable members. I would just like to respond to the one question on the turnaround time. Chair, we basically have started the digital transformation journey of the CMS. We have put in plans in place and a project heat map to revamp the technology that would help the CMS in the current infrastructure challenges that we have. And while that is happening, Chair, in parallel, we'll be also managing the current systems, which are old and aged, as well as upskilling the team so that we can actually also manage the new technology as we're coming in. The turnaround time, Chair, over a period between the digital strategy talks to between 3 years, 3 to 4 to 5 years, because these are big technologies. We're going to have to revamp the technology. We'll have to take out the old and replace with the new. So there's a lot of, data migration, a lot of those processes that need to be followed. It must be valid, accurate, and complete data. And we also have to move towards the cloud because of, as my colleagues have iterated, the old and aged infrastructure. And that is where the technology landscape is currently going. Thank you, Chair.
Thank you very much, CIO. Chairperson, that completes our presentation. Thank you.
Okay, thank you very much for your presentation. Please note that some members have commented about you to address the AG's findings, actually including improving our internal controls. And thanks for that issue of irregular expenditure, how you have really dealt with it. Members are really pleading that you probably don't go back there again. And also continue to allocate sufficient resources on that part. I've always said when you continue with a particular contract of a service and then get an irregular expenditure because of that, it's choices that we make. Because I mean, a contract is like knowing when is the birthday of my firstborn and a secondborn. So on that day, you prepare that on that day, this contract comes to an end. And therefore, if it took you 4 months to get to that contract, then it means you need 4 months before this one expires to get to a new one, so that the processes are not actually doing you get irregular. So I always think having irregular expenditure based on service contracts that have actually been extended beyond the expiry date is choices that we make, because it's choices that we can also not make. We also would like to really ask you to continue developing and implement consequent management policies where you can. If you could actually continue to also provide us with quarterly reports on how you strengthen oversight, particularly on these audit outcomes and findings. We are glad that you are telling us you continue to work with the Department of Health and other stakeholders in reshaping the role that you are going to play on our universal health coverage and for now and beyond. And we wish that you continue to do that. Please do strengthen public education on medical schemes options for members. I don't know how you could do that. Some members suddenly do not have so many options and they don't know. So I don't know how you do that, whether you leave it to individual medical schemes to do it, or you could also play a role in maybe encouraging them to do so, so that our citizens can be actually educated and be able to know, what am I buying? I mean, you buy a car, they tell you after so many months, it will expire its motor plan, therefore you need to do options and this and that. So some other members are participants, but do not really fully understand what is the product that they do have. And I think you could also play a role in supporting and making sure that they do that. With that, Chairperson, thank you very much for your visibility and your availability. You know your staff very well. It's as if you are not a chairperson, but a staff member of CMS. Congratulations and thank you very much. You are now released to take a break. Maybe you can have your closing remarks. But honorable members will only take a 5 minutes break, and at 20 past, SAHPRA will be logged in, and we hope they'll be assisted to make sure they start exactly at 20 past 11. But Honorable Chair, maybe you could then have your closing remarks. Thank you very much.
Thank you so kindly, Chair. My computer is frozen. I can't even unmute or switch off my camera, but I preferred to stay on so that I can be here till the end. Honorable Chairperson, the Council for Medical Scheme wish to thank you so kindly for your guidance. And we wish to indicate to the committee that Council CMS in particular is committed in delivering its statutory mandate, and it will continuously engage, as the Chairperson has alluded, that they will appreciate a quarterly report on the governance and how we strengthen our oversight, which deals with Council itself. And we want to commit ourselves that indeed, Chairperson, we will communicate with the Portfolio and Health Committee to appraise the committee on the developments and the progress of the entity. And we humbly and appreciate the opportunity that has been given to us this morning. And thank you so kindly. A very special good morning, Chair. Thank you so much.
Thank you, ma'am, and have a good day too with your team.
Thank you so kindly.
4 minutes break. Honorable members, grab a cup of coffee, tea, water, back to your desk and walk about in the room. Okay. Honorable members, I hope you have been able to grab a cup of water, a cup of tea and a glass of water. Let us continue on our work today. We are welcoming now SAHPRA leadership led by Dr. Semente, and we will now give an opportunity to them to take their 45 minutes presentation of their report. Dr. Semente, we would like to welcome you and indicate that we have received your report and have read it, so you may not go on it on line by line. You would just have to support us to understand it. Or I also noticed that the chairperson, Professor Rees, is also joined us, so you will indicate who starts. So we will engage with your report after your presentation, but we have also reflected on it. So take it that it is read, but also still to take us through it within your 45 minutes. Thank you very much. Maybe the chairperson will start. Over to you now. Thank you, Professor Rees.
Thank you very much, Honourable Chairperson, and thanks so much for this opportunity to present. I will hand over to Dr. Smeti to introduce the executive team who are with us on the call, and she will go through the slides, as you say, as quickly as possible, so there's time for discussion. But just to say, from the board perspective, as we discussed when we were in Cape Town, the board has been very satisfied with progress, both in terms of clean audits and just the tackling of a lot of new regulatory issues that are coming our way, but also and I think the CEO will go into this, very exciting developments, I think, in the African region, liaison with other regulators, harmonization, exchange of information and ideas. And so I think we're in a good space. But with that, I will hand over to Dr. Smeti, who will introduce very briefly her executive team. But thank you, honorable members, very much for this opportunity.
Thank you very much, Prof. Rees. I'm not sure what's happening with my camera. For some reason, I can't open it. But I've got my executive team with me, and just to introduce ourselves, my name is Tumi Semete, and I am the CEO of the South African Health Products Regulatory Authority. I'm here with the executive team, and I see some of them have the same problem with my camera, similar to my camera, but I'll start with Kristalna, who is our COO. Kristalna, do you want to quickly introduce yourself?
Certainly, thanks, Dr. Tumi. Good morning, everyone. My name is Kristalna Reinicke. I'm the Chief Operations Officer for SAHPRA. Pleasure to be here.
Thank you. Rehat?
Good afternoon. I'm Rehat Khaz, the Chief Financial Officer of SAHPRA. Apologies about the camera.
Thank you. And Joe?
Good morning. My name is Joe Mudisekeng. I'm the HR executive for SAHPRA. Apologies for my camera as well.
Thank you. And Itumeleng?
Good morning, everyone. Itumeleng Khosana, responsible for business planning, monitoring, evaluation. Apologies for camera. Thank you.
Thank you, Chair. We seem to all be having the same problem with the video, so we'll just switch those off. I'm going to share my slides, Chair, and it seems it does work. Thank you. I trust that you can see my slides. So thank you for the opportunity for SAHPRA to present to the Portfolio Committee our annual report for the 2023-24 financial year. Before I start, Chair, I just want to mention that we've got one executive position that is now vacant. This is the position of the Chief Regulatory Officer. However, we are in the position of filling it. And one other member, apologies that I forgot to mention, he's also an executive, Mpo, who's our board secretary. He is also here. I was just struggling to see names.
Good morning. My name is Mpho Mpilo. I'm the board secretary, and apologies for the visuals. Thank you.
Thank you. Apologies, Mpo. So I'll go into the presentation, Chair.
And I may interrupt. This is Prof. Rees here. There seem to, on my screen at least, there are 2 black boxes. I don't know if other people are seeing these as well. I mean, we have the slides, but to the right and at the top, there are 2 black boxes.
Yes, we're seeing that.
Okay, I'm going to try again. We seem to be battling with Zoom.
Are you used to Teams?
Yes, sir.
This one is the easiest. Zoom is easier for us.
I wonder whether Mpo, as is Prof. Rees here again, I wonder whether Mpo could perhaps share, and we've got rid of 1 black box at the top. We still have a black box on the right-hand side.
See? And what about now? It should be gone now?
Smaller black box.
It's gone smaller.
Yeah.
Yes, it's really gone.
Okay, great. Apologies again. So, Chair, we'll take you through our performance over the last financial year, but also just utilize this opportunity to recap in terms of who we are as a regulator and what it is that we do. So briefly, as a regulator, we operate in a very global sphere, but we're very cognizant that, as our vision is indicated here, that we are an agile and a responsive African health products regulator that is globally recognized as an enabler of access to safe, effective, and quality health products. Quite important to our mission is to highlight to the committee that we promote access to health products and we regulate health products for both the human health as well as the veterinary sector. To that effect, there are 2 acts that really guide what it is that we do, being the Medicines and Related Substances Act, Act of 1965, which was amended. And we're currently busy, Chair, with the project to review this act and in essence overhaul it. So quite soon you will be hearing from us through the National Department of Health, where we will be bringing to yourselves a revised act for SAHPRA. We also regulate the area of radiation control for radiation emitting devices, and this is governed under the Hazardous Substances Act, Act 15 of 1975. And for all the products that we regulate, there is 3 fundamental, very important pillars to our mandate. The first is to ensure that the products that we regulate are safe, that they're safe even when utilized under a clinical trial, and that even once they are registered, when these products are in the market, we analyze their performance and their safety. Furthermore, we look at quality. Again, we look at quality of a product throughout its life cycle, pre-registration, as well as once we've registered the product. And the last important pillar to us as a regulator is the efficacy of the health products that we regulate. So they must do what they claim that they are to do, and we monitor that through clinical trials. We evaluate the data presented to us, and again, when we've registered these products, our work does not stop. We assess them even post-registration. From a governance framework, Chair, we are now in our 7th year of operation as a Schedule 3A public entity that reports into the Minister of Health and to yourselves as Parliament. And this is done through our board, represented today by the board chair, Prof. Helen Rees. And this is our board that has been appointed. There's 1 member who was recently appointed, whose picture we are yet to include. As I indicated, Prof. Rees is the chair of the board, and Dr. Obageng Kaule is the deputy chair of the board. This board is currently appointed until June 2025. Over the years, Chair, we've focused on a number of areas. As I indicated, we're now in our 7th year of operation, and we really had to first start by establishing this Schedule 3A entity, which what used to be a directorate within the National Department of Health. We have spent a significant amount of our time ensuring that we've got the right policies and governance procedures in place, that we strengthen our executive team and our senior management team to ensure that we can, as an organization, be a high-performance organization, make sure that we are professional in how we work, and that we are a compliant organization. And to demonstrate our ability to do so, in the year 2022-2023, we managed to clear the backlog that we inherited from the Medicines Control Council. And also we managed to achieve the WHO maturity level 3, and we are one of the 6 African regulators who have this maturity status. And basically what it says is that we are a well-functioning regulator that has integrated systems and is globally recognized. Also in the 2022-23 financial year, we had an unqualified audit opinion. What our focus now is to ensure that we really position ourselves as a knowledge organization. If you look at the work that we do, we must ensure that we've got very strong technical expertise to be able to review the very complex products that we receive to make regulatory decisions. And our plan is that we must have a significant amount of this capacity internally within the regulator. In the last financial year, Chair, I'm very excited to highlight to yourselves that we managed again to have an unqualified audit opinion that resulted in a clean outcome, and the CFO will speak to that in a clean audit outcome for the 2023-2024 financial year. And we're very proud of this because we remember when SAHPRA was established in 2019-20, we had a qualified audit opinion with a significant number of findings. So the team has worked really hard to ensure that we are an organization that complies with good governance practices. In addition, we've been able to get certification from the South African Bureau of Standards, and we're now an ISO 9001 certified regulatory authority. The environment, Chair, that we operated in the past financial year required that we operate in a very international sphere. I'm actually speaking to you now from India at a meeting of all the regulators across the world. And SAHPRA, I must say, is getting a lot of accolades in terms of the work that we've been able to do, but also the rigor that we apply in the regulatory decisions that we make. And for us, it is important that globally, SAHPRA is recognized for the work that it does. An additional point is that, as I indicated, being a knowledge-based organization, we need to ensure that we've got the right skills, we've got the right capacity. And at the moment, we remain to be undercapacitated. With the amount of applications that we get, we are certainly understaffed. And we've looked at mechanisms of how to attract and retain top talent, but it remains to be one of our biggest challenges. Thirdly, it is important that we are a sustainable regulator. We did mention when we presented to yourselves that we do receive allocation from National Treasury. However, this has been declining over the years and making us more and more reliant on fees. However, as a national regulator, it is important that the state does also support a national regulator. And so we constantly make a case for SAHPRA to receive a much greater allocation from National Treasury. And lastly, for us, as I indicated in the last financial year, we worked very hard to ensure that we are an organization that complies with principles of good governance and compliance with quality management systems. With that said, we managed to achieve 68% of our targets. There are targets that we're struggling with, and I'll speak to these in a bit more detail, but overall, we managed to achieve 68%. From our leadership and support perspective, and the CFO will take us through the last set of slides on the finances, but we are doing quite okay, wherein we had a total revenue that amounted to about 435 million against a budget of 381. And this really was driven by the external funding that we're able to raise to support us, especially with some of our projects like digitization and filling some of the roles that we have. In addition, we're focusing a lot, Chair, on our information management technology, wherein we have started implementation of the regulatory information management system. This is a project that is driven by our COO. And again, digitizing a number of our functions. And with this said, and all the challenges that we've seen around security and the threats around breach of IT security, of IT systems, we are looking at the structure of our IT team and looking to bolster it with expertise in information security, data security, etc. From a communications perspective, we have done quite well, and we learned a lot of lessons during COVID, that we really want to be positioned as a regulator to be the trusted source of information when it comes to health products. So over the year, we had a number of workshops, we had a number of webinars, and those were largely focusing on matters that affect the patient, such as pharmacovigilance. We had a number of webinars where we were sharing with the public how to report adverse drug reactions, how to report if they find products that are substandard and falsified. And we've seen a lot of improvement in terms of reporting by the public on this matter. Human resources, as I said, is one of our important areas. We always say to our staff that they are our greatest asset because we utilize them to do these assessments. And to that said, we did a staff satisfactory survey, which highlighted a number of areas that the staff was quite satisfied about. But there were also other areas where staff was unsatisfied on, which led to poor staff morale. And I must say, Chair, that since the completion of the survey, we've put in place an implementation plan. And part of that implementation plan was to strengthen our HR office. And we have a newly appointed HR executive who introduced herself, Ms. Jo Mudisakeng, and she's really, her and her team, in a very short time that they've been with us, have done a really stellar job in trying to ensure that we are a stable organization that works really well with the unions, with the labor unions. Chair, I'm not going to focus too much on the targets that we've met. It would be great, but I take this report as read. But I must highlight that in the prior year, which was 22-23, we did have an unqualified audit opinion. And in the 23-24 financial year, we then had a clean audit outcome. I'm going to skip those that are green, but just want to focus on the training that we offer to our staff. This is a target that we have met. Again, acknowledging that we are a knowledge-based organization that must have these technical skills. We invest a lot of our resources into training our staff, and not just locally, but with other international regulators. We have struggled, however, Chair, to fill the roles that we had targeted to fill. And really at the core of it is issues around our salaries. I heard the colleagues from the CMS mentioning that they had done a benchmarking exercise, and that's what we have embarked on. Because when we look at the salaries of where we attract talent from and where we lose talent to, those salaries are completely above what our current pay scale is. So we've started that process, and we will be benchmarking our salaries so that we can offer competitive salaries and attract the right candidates. From a turnover perspective, while we are losing people, it's still within a norm, and so we're not too worried about that. We did have, Chair, however, some challenges with implementation of our digitization project, and really at the core of it is the delays in the procurement process, because we really needed to ensure that we appoint service providers who are very familiar with the environment, the regulatory environment, and would be able to deliver these services at the price that's required. However, we have subsequently appointed service providers. From a health product authorization perspective, which is one of our programs, we are working very closely with the region. We have a regional regulatory mechanism wherein an applicant can submit in this regional mechanism, and it will then be a collaborative review of the application by the authorities. This regional mechanism is called Zazibona, and these were the founding members: Zambia, Zimbabwe, Botswana, and Namibia. But now there's 13 other very active participants in Zazibona, and this is under SADC, and South Africa is one of those. Within this area, we managed to meet our target for the timeline that we take to finalize new chemical entities, as well as the timelines to finalize generic medicines. These were two targets that we would struggle with quite a lot over the last few years, but with the implementation of reliance mechanisms, but also driving a lot of optimization efforts within the organization, we've been able to meet these targets. However, I think we're still not out of the red, Chair. We need to ensure that we increase SAHPRA's capacity to be able to comfortably deliver on these targets. There are instances where we had to have staff work overtime for us to be able to meet these targets, and that is certainly not sustainable. We did manage, as I indicated, to get our ISO 9001 certification. However, we were not able to conduct the self-assessment for maturity level 4. And really, this was because of many competing priorities, and we had to deprioritize this, and it will now be done in this current financial year. From an area of inspectorate and regulatory compliance, so this is a team that goes out and inspects the facilities that manufacture these health products. And also, when the products are in the market, they inspect those facilities for compliance with the Act. And this is an area where post the implementation of our whistleblowing platform, we've received a number of reports of non-compliance by whether it's healthcare professionals or industry. And so we've seen a really an increase, a significant increase in the work that we do in this area, and we thus need to increase the capacity we require for this area. This is also an area that requires for us to work very closely with the law enforcement agencies. Some of you may have seen it in the media, where we work with the South African Police Services to confiscate some of these products. We work closely with the Pharmacy Council and the HPCSA when it comes to the professionals that contravene the Act. So in this area, in the area of issuance of licenses, we've struggled with this target, and it's really because we are resource constrained. Yes, there are areas to optimize, and we are busy with those now, but at the core of it here, we need to increase the number of inspectors that we have. From a permit perspective, we were able to meet that target. And as I alluded to earlier, we've seen an increase in the number of complaints received. I mean, if you look at the bottom here, we indicate that we'd received 430 complaints. And so these complaints require that our team goes out, assesses the facility, looks at the products that are non-compliant, and then makes a decision. And so again, we need to make sure that we work closely with the stakeholders that I mentioned earlier, including the Border Management Agency, who we've written to, so that we can have an MOU in place, because there are products that are coming into the country that are not compliant. And then the second last area I'll speak to is the clinical and pharmaceutical evaluation. So this is the area that evaluates the products for efficacy and quality, but also the clinical trials themselves. I'll move quickly. In this area, we managed to meet quite a number of our targets, with the exception of review of safety reports that we receive. Again, because we've done so much awareness, we're getting a lot of reports by the public, a lot of reports by the healthcare professionals. We've also partnered with the provincial officers, and we've got great support from the Minister of Health, who's written to the provinces to work with us in this effort. And so we've got a national pharmacovigilance mechanism, and we need to increase the human resources in this area because of all the awareness that we've put in place and the coordination at the national level. This is just, you can see a list of some of the awareness campaigns that we've had, and this spans the entire country. We really work across many areas. And then we met the target on the lot release. I'm going to skip that one. In terms of the area of medical devices and radiation control, these are two areas that were introduced into our mandate when SAHPRA was established in 2017-2018. So there's quite a lot that still needs to be done in terms of putting in place the fees, finalizing the regulations for registration of medical devices, and also optimizing the area of radiation control. The target that we did not meet was where we had indicated that we want to issue a call-up notice for high-risk products. So we would then communicate to the public, to industry, that they must have these products registered. However, there were delays with the gazetting of the medical device regulations. And so we were not able to meet this deadline. And the last one, Chair, that we were not able to meet is publication of the guidelines. Again, this would be affected by the lack of gazetting of the medical devices regulations. And so hence we did not meet this target. From a human resource perspective, Chair, I think we're a very well transformed organization. You can see in the numbers that are indicated here. What you will also note is that not quite indicated here, but we are an organization where we have a very young staff cohort, with our average age being around 40 years. And so we do have a very mobile health workforce, and that's affecting, our efforts of retention of these individuals, but also it creates an opportunity for us to have very good succession plans in place for these people to then be in senior management positions. I'll hand over, Chair, now to the CFO.
Thank you, CEO. Just the audit outcomes as reflected by the CEO over the past 5 years with 1920, with qualifications that we received, and then in the end, 23-24, the latest audit outcome, clean audit, and specifically where we struggled a bit on the material non-compliance areas we were able to clear in the latest audit, attending to financial statement adjustments and revenue management. Glad to report a zero balance, irregular, fruitless, and wasteful expenditure that we've reported following all the condemnation processes as required by the National Treasury, and also no material financial statement or performance information adjustments made after the submission of that information for audit. Next slide. On the finance side, just a year-on-year revenue analysis. SAHPRA with the dark blue column, which is our own fee income, has significantly increased over the past few years from 169 million to 228. The year-on-year increase for the past 2 years have significantly slowed down, though, to about only 16% or 29 million rand per year. The government grant, which is the lighter blue bar, does show a significant reduction of around 10% or 15 million from 23-24 and over the NTF period with the austerity measures that was implemented. And that does show a downward trend. Also noting that in 1920, there was additional funding received for the backlog clearance project. But basically what the graph shows is that for SAHPRA to remain, or our reliance on our own fee income is the only way to remain financially sustainable over the long-term period. Thank you. Next slide. With the fee increases or own fee income increases that we've experienced over the past few years, the graph on the left just indicates where this was basically invested, and it mainly went to our cost of employment, where we see an increase of cost of employment from 119 million in 18-19 to 248 million in 23-24. And this is as per the plan of filling our vacancies and utilizing the own income that we're generating to reinvest it into cost of employment. However, as CEO indicated, we still have a number of unfunded vacancies that were never budgeted for. And as we increase our own fee income, we're planning to fill those over the NTF period, although it is a challenge based on the current revenue trends. The graph on the right-hand side just indicates the fee income as how it has grown compared to the government grant that we've received over the past few years. Next slide. From a statement of financial performance point of view, revenue versus expenditure, basically, we were able to maintain over the past 3 financial years an accounting surplus, and that's mainly due to the additional revenue that we've generated that was not foreseen, and also some challenges in cost of employment expenditure that was under budgeted, as CEO explained, with the challenges that we've had in filling some of those positions. We do see the accounting surplus reducing year on year, especially the last year, about 50%, and mainly due to the operational grant that has reduced. We do expect this trend over the NTF with the anticipation that a revised fee gazette that we're waiting approval for will mitigate the possibility of future accounting deficits over the NTF period. Next slide. This is just an analysis of our expenditure per program. This basically indicates what I want to flag is the percentage spent on our administrative activities, which is program 1, and it's about 37%, and most of it is in relating or in support of our core programs, which is program 2 to 5, which is about 63%. So you see basically a third of our budget going for administrative support to the core units and 2/3 being spent directly on core business operations. Core business operations are mainly driven, the expenditure there on cost of employment, and on average about 90% of the budget or the amount spent from program 2 to 5 is on the cost of employment due to the regulatory work that we're performing, with the exception of program 4, which has a big component related to the National Control Laboratory that does the batch release testing for us per financial year. Thank you, CEO. That was my last slide.
Thank you, Chair. This is the end.
Thank you very much, Professor Reeds, Chair, and Dr. Semente, the COO and your team. If I were to ask, is a CFO a left-handed person? Dr. Semente?
Not to my knowledge.
I looked at the audit. I looked at the audit outcome graph.
Oh.
It was moving from right to left. So the left, which is what we were seeing, is what is current, and the extreme right is what one would have put it as left. So we always look at left-handed people doing things the other way around. But thanks. Honorable members have already started raising their hands to clarity seeking, and the hand that stood up first was that of Dr. Tembekwayo, followed by Honorable Van Staden. The third one, Honorable Shabangu. I recognize Honorable Motubatse and Honorable Sene. This time around, they beat Honorable Clark. She's number 1, 2, 3, 4, 5, 6. You stayed number 6, Honorable Clark. Honorable Total Letape, number 7. And then Honorable Leroux, Total Leroux, you number 8. In that order, honorable members, you can start.
Thank you, Chairperson, and thanks to the department for the presentation also. My first question is the AGSA stated that SAHPRA figures were restated due to errors in the entity's financial statements for the year ended in March 2024. Can you explain on contingency plans in this regard? The second question, the AGSA stated material impairments of 5.155 million due to the entity's inability to recover it from its creditors. What is your stricter plan to recover the monies? And the following question is based on, in the response to the question that I was going to ask based on whether you have dealt with the outcome of the employee satisfaction survey held on 18 to 28 September, where the employees stated that they see culture in your department as toxic, very much uncaring. It confuses staff, it's bad, it's segregated and dysfunctional. And as a result, some expressed a feeling of unhappiness and the discouragement. So yes, you mentioned that you need to retain a talent as part of the response to this question. And yet the top talent that you have or you need to retain is not satisfied with the governance style of your department. You advocate for good governance as your mission, but it's not good governance as expressed through the survey. You are intending to add more staff to the department to a still toxic culture. How will you do that if the present staff is not satisfied and their complaints are not listened to? Yes, you have mentioned that you have strengthened the HR office by appointing a new person. Yet recently, I'm talking about this week, after you have maybe appointed that person, I don't know when you have appointed that person in the HR office, I've received some complaints, very dire complaints, that says a lot on the survey that was conducted. And they are not listened to. They are not given a platform to can express their problems, or they are not listened to in actual fact. That's why they decided to extend their help to us, and the chairperson of Health, Dr. Dlome, is also part of this. He was also copied. So we need to engage with your committee to get their complaints solved amicably too. Not for the person that complained, and at the same time they end up losing their job because they had a complaint about their executives. So I'll leave it to the chairperson, and then he will say something about that section. And then the last question is based on the clinical trials. Is there a mechanism to ensure that all clinical trials accommodate both rural and urban, and also include all demographics, not only Africans? Thank you.
Honorable van Staden.
Thank you, Chair. Now, I also want the explanation about the material impairments of 5,155 million rand. I think we need the explanation on that and measurements to rectify it. And then can we please get an update on plans to enter into agreements with Japan's Pharmaceuticals and Medical Devices Agency, the Health Canada, and the Australian Therapeutic? And then maybe SAHPRA can answer this question to me. What is the situation regarding the Mpox vaccines? Do South Africa have enough stock, or are there still negotiations taking place around this matter? Thank you, Chair.
Okay, thank you. Honorable Shabangu.
Thank you, Chair. And thank you for the presentation of the report by the department. Honorable Chair, the report indicated that SAHPRA need top talent, and which of course the top talent and the stability. And on the same breath, it's said that the staff turnover create opportunities for succession plan. And for me, that is a bit contradictory, because if you need top talent, you need continuity to stabilize the department. I'm concerned that that might ignore the real issues that needs to be addressed for staff retainment, because this is the department that really needs top talent and skills. And as much as then there was mentioning of staff survey, which also what I've picked up is the outcome. One of the outcome was staff low morale. I'm not convinced that it was properly addressed, that issue of staff morale. There is mentioning of benchmarking the salaries and all that, because this is a competing environment. You need the top talent. But I'm not convinced. I didn't get it clearly. How are they addressing the low staff morale? Because that can affect their performance. And there's also workload that was also mentioned. And with that, I didn't hear anything. The second one, it's one would want to know, how is SAHPRA adapting its inspection and enforcement activity to address this growing demand for cannabis-related economic activity in the medicine space? It has been in at play for quite some time that there is a demand for this cannabis-related as in the medication. So we just want to know, how is this taken up, and how are they adapting in the inspection and enforcement activities in that space? Thank you, Chair.
Okay, Honorable Mutubatsi.
Thanks very much, Chair, and I also welcome the report. I think quick few questions. On the question of funding, you mentioned that you are receiving funding apart from the government grants. Who are actually your funders, and what are the conditions, if any, of people who are actually funding you? If you can disclose who are your funders and how much are they actually funding you to this level? Secondly, just to find out, are you in sync with the current tobacco bill that is currently in circulation, or that is currently on the table of the portfolio committee, which has been in circulation for some time? And what do you think should be your role in that regard, or is there any advice on that particular bill? Thirdly, is on the indigenous medicine. What is your role, and how far do you think you can actually go in actually assisting us to take this whole of indigenous medicine coming into the professional space? Yeah, I think those are the three questions that I want to put forward. Thanks, Chair.
Okay, this indigenous medicine question comes often, Honorable Mutubase. So I would want to say to them, they must just declare when are they going to give an update, so that we wait for that once and for all. Honorable Senne.
Thank you very much, Chairperson, and thank you for the presentation. I'm covered on the staff survey by Dr. Tembekwayo and also Honorable Shabangu. And then I also want to find out with SAHPRA, what is the timeline for the full implementation of regulatory information management system, and what measures are being taken to address the delays and challenges encountered in the project? And then my second question, Chair, is what strategies are in place to develop and upskill employees to meet the evolving needs of the organization, particularly regarding the introduction of new technologies like RIMS? And then, Chair, my next question will be, what opportunities for collaboration with international regulatory authorities are being explored to enhance SAHPRA's capacity and expertise? Thank you, Chair.
Okay, Honorable Clark.
Thank you, Chairperson. Could SAHPRA please expand on the resource constraints in the inspectorate and what measures are in place to ensure that this is addressed? And then why the attendance of board members to scheduled meetings is inconsistent when all of them were appointed in October to December 2021, and also explain the disparity in board fees from R0 to 245,584. What are the reasons for this? Then also during COVID-19, the authority was litigated on various grounds. Has SAHPRA been litigated during the reporting period? And if so, please explain. And then, Chair, I really want to understand what the backlogs are at SAHPRA and what are they doing to mitigate this? Because I can tell you, I get weekly complaints from people because their products it's been taken so long for SAHPRA to finalize on their products. So how do you deal with those aspects in order to mitigate those long waits? Thank you very much.
Okay, Honorable Dr. Letlape.
Thank you, Chair. My question also relates to the issue around revenue and affordability. What would be the impact on revenue in terms of possible cross-registration with the SADC 13? What I mean is, are you going to recognize products that have already been registered in different jurisdictions? Could that lead to possible loss of income because you wouldn't be charging the relevant fees? And linked to that, as you benchmark to be able to retain staff, do you implement in accordance with affordability with your resources? Because I've seen that in some institutions, a gap then rises and you open yourself to labor disputes where your income is not commensurate to the promises to employees. The next question is, how do we ensure benefits to participants post-study conclusion, usually on medicines that are found to be effective, but are highly expensive because they would still be new? And the last question is, we've just had an outbreak of a Marburg virus in Rwanda. What is our readiness in South Africa in terms of the relevant vaccines to Marburg virus? And are there any things that are being done in terms of screening since we have air traffic between Rwanda and South Africa? Thank you, Chair.
Thank you, sir. Honorable Dr. Leroux.
Thank you, Chair, and thank you for the presentation. Most of my questions have been covered. I just wanted to find out, in the performance indicators, you spoke about the medical devices issue and the delay in the gazetting of this legislation. And you also mentioned that there is a possibility to be getting some income from that, from the process of you have overseeing that. Can I just get a sense of what you expect your income to be if that does go through, and when do you expect for that income stream to open up? Thank you.
Yeah, thanks, honorable members. Related to what some of the members have asked about Mpox vaccine or any other, mine would be to say, so that we as South Africa and Africa do not go back to where we are at the back of the queue. I know your role is to actually register and approve. What role do you play when there is a whole host of scientists, researchers in South Africa, in Africa, to prepare processes and maybe allow them to, maybe what is going to come in as your response to Honorable Clark, some of the products that come your way to jump the queue, because of other, if they are registered today rather than next week, the impact might be much more significant out there as they may be needed. So how do you navigate that? And you probably do it. Number two, just expand a bit of your globally recognized entity that is SAHPRA and the role that you play. Your footprint, this is now not only in Africa, like it extends beyond Africa, even in India. I'm interested more on what would be your role, advice, and a guide as South Africa will be taking the G20 presidency of this year. And that not only stands to benefit South Africa, but the whole of Africa and maybe the global South, your involvement, because I think we are one of the very few regulatory authorities that are very strong on the global South. I've always thought I would ask this, but now that someone has asked, one of them have asked, your relationship with Department of Agriculture, them releasing, because you are actually giving registration of cannabis for medicinal use, and also you have an influence on the cannabis registration for commercial use or agriculture. So that part seems to, and then one of them is easier, other one is difficult. Lastly, yes, Honorable Dr. Tembekwayo made me aware by sending me some of the documents that she has received as like complaints from some of the members, and that was only yesterday. So we indicated that maybe without making it a whole portfolio committee, we will be closer to that process as it has been sent to her. And myself, it's just that I didn't have time yesterday and today to look into what actually are the staff members raising with regards to that. So it has not gone very far from having been notified by herself and forwarding me some documents on that. I just thought I should also mention that part. So Chairperson, Professor Rees and your team, you can now support us with your responses. Thank you very much.
Thank you very much. Well, I think I'm going to ask the CEO to come in first and answer what she can, and she can refer, and then I can complement other matters that I think probably would fall more into my domain. But I'll ask the CEO to come in and to pull in the appropriate executives as required. Thank you very much, honourable members, for these very comprehensive and insightful list of questions. Thank you.
Thank you very much, Prof. Rees, and thank you, members, for these questions. And they do cover all the areas represented by the executives here. So I will ask them to address some of the questions. If I could start, in terms of, I'll start with some of the technical ones around the clinical trial. So when we evaluate clinical trials, depending on the product, depending on the study objectives, the PI, the principal investigator, and the team, they would identify participants, linked to that. It's really linked to what are the endpoints. But we do look at matters of ensuring that the population group is diverse enough. I mean, one of the really big topics in clinical trials is diversity. And so we do certainly look at that. But again, it depends on the therapeutic areas. But the points you raise around rural and urban areas, we'll look at it. But it really depends on the study. And I must say, for South Africa, a lot of the studies are done across the board. And Prof. Rees is also an expert in this area. Maybe she'll also comment on that. There was another question in terms of post-trial access. So this is something that we've built into our policy. It's part of our good clinical practice guidelines, the South African good clinical practice guidelines, that there must be post-trial access. So that's written into our requirements, and it is quite well implemented in the country. The other question that I'll talk to is around partnerships. We got a lot of questions on that. So some of you may have seen this week, we published that we have entered into an MOU with the Australian TGA, and we have MOUs with a number of other regulators in the continent. but as well as outside of the continent. And really these MOUs are to facilitate information sharing, that to facilitate training, and really being able to cooperate on common areas. So for example, with the TGA being in Australia, it's one of the agencies that we rely on. So if they've done an assessment of a product, they will then share their report with us. And instead of us doing a full review, we would consider what it is that they have done. And this is important. We were asked a question around the backlog. One of the honorable members mentioned that they get complaints. And I must acknowledge that this is an area that we're still working on. Again, it's driven by lack of resources. Our current staff complement is about 313 or so. And when we look at what we need to be, we need to be at least 500 staff complement, with a significant amount of those people being technical. We're nowhere near there. So hence I continue to make a call that we need to be adequately funded as a regulator so that we do have the resources that are required. When you compare us with some of the regulators across the world of countries of our similar size, we're really small as a regulator, and that's what adds to us taking so long in reviewing the time frame. So again, if there's anything we can ask this committee to assist us on, is to make a case with National Treasury to fund the regulator so that we can be adequately capacitated. With that capacity, there was a question around grants, who funds us and how much. And we're very transparent about this. If you look at the annual report in the financials, we do list exactly who our funders are, whether the funding is in kind or whether the funds were made directly available to the regulator. We do have that in the report. Please have a look at that. It also indicates how much they've made available. And in the report, we would also then talk around the funds. But if I could just mention a few, we have the German government, GIZ, which has helped us with the digitization. We have Global Fund through the National Department of Health. They've assisted us with some of the positions that we needed to have filled. We have the Bill and Melinda Gates Foundation, quite a number of funders. So again, this is captured in the report itself. There was a question linked to, I'll go to Mpox vaccine. So we're working very closely here with the National Department of Health. We've received the application from Bavaria Nordic. This is for the Bavaria Nordic MVA vaccine. And we will be finalizing the review. They finally submitted the dossier about 3 weeks ago or so, and we are evaluating. We know the quantities that the department now requires, and within the next couple of days, if not a week at the most, we will be able to make a decision. We are relying on the decision of the WHO. You may be aware that WHO has pre-qualified this vaccine. So we're not doing a full review, but we are assessing this vaccine. So this will make sure that then the country will get the stock that's required for the vaccine. The issue of human resources, it spans across the area. I've alluded to why we have a backlog. And it also speaks to the area of inspectorate. We don't have adequate capacity. And really this is, we send our people to all these different facilities across the world. We don't only inspect facilities in South Africa. And so we need to make sure that we have the adequate capacity. And all we need really is to employ the people with the technical expertise to pay the people commensurate salaries. And we're able to train those people internally. There was a question around upskilling. We work closely with other regulators. As we speak, at the end of the month, we have 4 of our staff members that are going to Swissmedic in Switzerland. They're going to be trained there. We had one of our staff member who came to the WHO for 3 months, beginning of the year, to be trained. So we do have numerous opportunities for our staff to be trained across the world. And then there were questions around the tobacco bill. So we don't regulate the area of tobacco. So while we may look at it from a health perspective and ask our legal committee to see if there's anything within there that we must comment on, but this is an area that we don't regulate. Unlike other countries, wherein tobacco falls within the medicine regulator. In South Africa, tobacco doesn't fall within SAHPRA, and neither does food, which is what's different between us and regulators in other countries. On the area of African traditional medicines, we've put together a committee that is led by Prof. Matsabisa, some of you may know, who's at UFS, the University of Free State, and they are looking at just analyzing what other regulators are doing in the space, some of the WHO guidelines and the context in the country, and they will then be making recommendations to us on how we could effectively regulate this area. But again, it would be limited to the products. There is an act that regulates the practice of indigenous health practitioners. So we wouldn't be involved in the practice, but rather the products. But that's still a project that is ongoing. And then I'll talk to the issue of litigation. Yeah, so as you rightly say, I mean, during COVID, we sat with quite a number of legal cases pertaining to the vaccines. And I must say, I think with all of them, we've been successful in most of the instances. We even have a cost order to us wherein the applicant must pay us cost. We report to the board on this on a quarterly basis. And what we could do is also include then a report on this in the annual report. But all our quarterly reports do have feedback on the litigation and what we've been successful. And I must say, we've done really well. And what helps us to be confident even when we go into these matters is that we make evidence-based decisions. And we make sure that every decision we make, we are compliant to the Medicines Act. And hence I started off even this presentation by highlighting the two acts that govern what it is that we do. And so I'm quite satisfied that we are following due processes there. I'll talk around the area of when products are submitted through the SADC MRH mechanism, Zazibona. So at the moment, what happens is that we're running a pilot through Zazibona with the fees, and industry has commented on the fees. They're happy to pay those fees, but they also pay fees to the regulator. So with all of these mechanisms, whether regional or continental, there's been an acknowledgement that it should not impact the fees that a regulator at a national level will charge. So we still charge the fees. In terms of the Marburg virus, yes, I saw, I think it was last week or so when some of the reports went out around this. We're still engaging with the regulatory community and reaching out to the community in the DRC around the situation there. But also in terms of our readiness, what we would typically do is just look at the pipeline and the products that we've registered, whether there are any that are relevant for a therapeutic area, like in this case, like the Marburg virus. And if there are no products, what we then do is we prioritize any application linked to that. And that's similar. There was also a question around how we prioritize products in a public health emergency. So we do that. We've got a framework that we've put in place. It's published, it's on our website, that says when there is a public health emergency, whether at a national level, continental, or a public health emergency of international concern, how are we going to operate as SAHPRA? So we have mechanisms to expedite all of these reviews. And then just the last 3 points around the medical devices fees. I'll ask Rachad to comment on that, but let me talk around our role as an ML3 regulator. So we play a role on the continent in what they call a regional center of excellence for vaccine. And so what it means is that we can support other regulators build capacity in the areas that we're strong in. But also at a global level, once you are ML3, you know, as I said, you are acknowledged as a regulator that has got that is functional, and others can then you know, rely on if they choose to, because reliance is certainly a choice. And so at a global level, I think South Africa has been recognized to be one of the strong regulator. I had a meeting this morning with the head of the European Medicines Agency, and they want to strengthen the partnership that they have with SAHPRA. And so I do think that we are well positioned as an African regulator operating at a global sphere, because really, I think we do very thorough assessment. And as I said, even with the legal matters, we make evidence-based decisions, and that's at the core of how we function. And then lastly, if I could comment on cannabis. So we've number of changes with cannabis. The first is that, we responded to the Concord judgment a few years ago. So therefore have then amended the schedules. We have moved all the permits and applications that are non-medicinal. They're now conducted by the Department of Agriculture. So anything that's non-medicinal does not come to SAHPRA. And when we transferred these permits, it was close to 90% of them were non-medicinal. So we only deal with a very small portion being medicinal. And in that case, anything else, whether it is for personal use, whether it's for recreational use, it does not come to SAHPRA. What we would make sure is that those that are cultivating it for medicinal purposes, they must be licensed. And when you're licensed, you therefore then have to, even when you commercialize that, you must commercialize it according to what you are licensed to do. What we're seeing is that the license holders may not necessarily comply with those requirements. And that's why we go and we inspect the facility, we look at who it is that they make the products available to. Because if they are non-compliant with the Act, then they've breached the Act. And then there's all the required consequences for that. And we've even had to suspend some of the licenses that we've issued because people are non-compliant. So we're being quite strict on this, because I think that's probably what also can cause confusion at times. But the large portion really is now with the Department of Agriculture. We met with the INCB, and they can also now report to the INCB on the usage of cannabis in the commercial non-medicinal sectors. Chair, I'm going to maybe start with the CFO and ask that he handles the first two questions around the financial statements, and also to talk around the fees for medical devices.
Thank you, CEO. On the question in terms of the errors rate during the financial year, it was detected by us when we developed the financial statements, and it's reflected on note 34.1 in the annual report, page 159. So the adjustments on the statement of performance and statement of position was not that material. It's just trying to make sure our figures are 100% correct. On our disclosure side, we did pick up some errors. One was on the commitment note, just a casting error previously not picked up, which we corrected. And the other one was on financial instruments, where we removed the deposits. So it's just a correction on being consistent in how we then make those type of disclosures. Going forward, I think we still have hopefully immaterial corrections to be made. It's just how we clean up, and when we pick up any gaps in the reporting previously, to correct those, but we do not expect material ones to be made. On the other AGSA comment on material impairments, so this related very specifically to to our medical device licenses. And basically what we found is it's also the type of industry that we're working on or in the medical device space. We did find some applicants would register, but not have the intention to continue with that. Maybe they registered for a tender, or the business aspects didn't look that fruitful, and they would just sort of disappear, which makes collection very hard. So we did appoint a debt collecting agency to assist us with tracing and tracking some of these applicants. The other thing we picked up is that on our database for medical device licenses, we are not cancelling them in time, which would result in possibly raising revenue again for them if certain conditions have not been met, for example, non-payment of a previous financial year. But it is part of our action plan, so we try to mitigate this, to collect as much as possible, to write off in time, and also to maintain the databases on a monthly basis. On the funding, it's note 19 and 20 in the annual report on medical device income. So what our intention is, or what we do in terms of determining fees, is a cost recovery basis. Medical devices are currently busy with a pilot project where they are doing a sort of assessment of how long it takes and what time it takes and what is the cost of completing a specific work stream. So once we collated that data, we will be able to determine what is an appropriate fee for to charge to industry. So once we have that, there's a consultation process and then a gazetting process. So it will take some time to enable SAHPRA to charge fees for that. By estimate, our review of our current gazette took about 18 months just to do our submissions to the Department of National Treasury. So it might be still a bit far off in terms of how much revenue would depend on our capacity and the number of products we would call per financial year. And thank you, CEO.
Thank you. We'll now address the HR related questions and I'll ask my colleague Joe to comment. But if I could just start by saying that indeed we did do the staff satisfaction survey and we got very specific findings within that, and we've developed an implementation plan which we've shared with the staff. And one of the areas of unhappiness is the salaries, and hence we are looking at benchmarking so that we can improve our salaries. The other issue is around the staff are saying they are fatigued. We do push our team quite hard to be able to deliver on the performance that you've seen today, with pretty much under just over half of the capacity that we require. So it does add pressure to the team, and some of the unhappiness could be about really being overloaded and in an under-resourced environment. So again, we're trying all we can to bring in additional capacity in a very tough environment. But we've been transparent with the staff on these issues and that we are addressing it. I would also like to ask that the feedback that's been given to you, please do share it with us. Happy to receive it in an anonymized format, because it is important for me that we deal with facts and we deal with specific examples so that we can then address those additional issues, because at least the survey gave us enough insight into what's happening. But if there's anything else that we're not aware of, I would really like to ask that you share that with us. I'm going to ask Joe to make comments maybe on the toxic culture, what it is that we're trying to change. Yeah, and just some of the HR questions.
Thank you, Dr. Dumi. So from HR, yes, you are right that our survey shows that as SAHPRA, we've got uncaring culture and toxic. And for uncaring, in SAHPRA on the 8th of November, we'll be launching our Wellness Day that we're going to be as well implementing the EAP program support. We didn't have ICAS before, so we've got a new company that's on board, Lyra, so they can be able to support our employees on financial well-being, their mental challenges and so forth. So at least on the 8th, just to cover the things that were mentioned on the survey, we'll be launching that. And as well, we've got change agents within SAHPRA. We had a meeting with them in September. So we're going to have training for the change agents and the leadership team, because to change companies' culture, we all need to do it together, ESCO and across the board with the employees. So we're partnering with them in the change agents. We've got the union members as well, so that we can be able to hold hands and change the culture that we have within SAHPRA. Dr. T, I'm not sure what other questions from HR beside the culture.
Thank you, Joe.
Thank you.
Kristalna, do you want to comment on the full implementation of RIMS? And then Mpho, I'll ask you to comment on the board fees, please.
Thanks, Dr. Tumi. Yes, so I think for us, quite important strategic initiative is the digital transformation of SAHPRA. And one of the key changes that we then effected earlier this year in April was to implement a new application case management and document management tool called DocuBridge. It's very much part of the overall regulatory information management ecosystem. And we have been running a concurrent process with the custom development for our SAHPRA engagement portal. Also having 2 of the 35 business processes digitized through that. and that go live date for the engagement portal, specifically around health product application management for new, renewal, as well as amendment applications, and then the applications for compassionate use Section 21 products also then being planned for April 2025. At the moment, very much still for us a priority. I think the main challenges, similar to Council of Medical Schemes, is funding support to progress the digital transformation. And as with the constraints that we're facing with the reduction of the grant from National Treasury, we have pursued then a course of action to seek external funding support in order to assist us to complete this digitalization of the various business processes. We are also looking at exploring different strategies in using artificial intelligence, specifically in support of some of the workflow automation, using some of the large language models to assist in administrative capacity in order for our technical staff really to spend most of their time on technical tasks and not as much time on administrative related tasks. So I think we have got quite a bit of work ahead of us in the next 3 years, and hopefully the funding support will continue to help us to move forward with this. And certainly, yeah, even the impact that the use of AI and all of these software tools will have on improving operational efficiency and allowing some of the resources then, as I said, to focus more clearly on the technical elements. Thanks, Tumi.
Thanks, Christina. Mpho, on the varied board fees.
Thank you, CEO. Firstly is the issue relating to the extension of board members' term. It has been extended by 1 year until next year, June 2025, to allow the department to engage in a process and dispense with the process of gazetting, inviting applications, processing the nominations, and assessment to be concluded. The issue regarding the directors or board members' emoluments, there are members who are employed by the state and or serving in one or more of the organs of state. They are not allowed to claim for attendance fees, preparation fees, etc. However, they are reimbursed for out-of-pocket expenses incurred. Those who are eligible to claim, they are paid for per attendance per meeting, and it depends on the number of meetings that the members will have attended, and also that the claims are received, processed, and recorded in the director's emoluments as it is disclosed in the annual report. Thank you.
Thank you, Paul. Prof. Rees, I don't know if you want to make some comments.
Thank you. So I'll just add perhaps to some of the technical side of things, questions asked. So on the issue of clinical trials, a clinical trial has to have 2 sets of approval. One will be from SAHPRA and the other one will be from a relevant ethics committee. SAHPRA in particular will look at safety, but will also look and say whether the trial design is going to get the desired outcome. And that will include who is the population included, the size of the trial, etc. Many of the larger trials indeed are will be in multiple sites around the country. For example, we've got, I think, about 40 sites at the moment, people participating in a TB vaccine study. So these are very large studies, and they will be in both rural and urban. But in addition, there is an increasing global discussion about making sure that the inclusion, which I think is the question you were asking, so that we don't have what we've seen in the past, that drugs are registered and the majority of the data, for example, in some of the studies that were done in high-income countries will come from white males in particular. So there is a real global discussion about diversity, and that also includes groups that you might not think about, such as pregnant women, because they're often left out, and that means that perhaps a vaccine that's very much needed hasn't been tested for safety and its effect in pregnant women. So, but it's an important question, and it's a very topical question that you're raising. But South Africa does, particularly for the larger sizes with different populations, will have both rural and urban, and it is something that ethics and SAHPRA would look at. The second thing on access to the MVA vaccines, this was recommended. I co-chair with a senior colleague from the Department of Health what's called the Incident Management Team. The DG has the right to set up these incident management teams in an emergency situation. And we have one on Mpox, which has been going on since the Mpox outbreak, shortly after the Mpox outbreak began in South Africa. For that group, we got a recommendation from NAGI, which is the National Advisory Group on Immunization. I also chaired that committee for the Mpox vaccine, recommending that we should procure Mpox vaccines. But I mean, my appeal to the portfolio committee and to the honourable members is we really need to keep the voice of the African Union going here, because once again, we had difficulty procuring the Mpox vaccines because many high-income countries in the Northern Hemisphere, because they'd previously had a large outbreak in about over 100 countries a couple of years ago, they have stockpiles. But to actually access the stockpiles was extremely difficult. What's very encouraging on the question of access is that the African CDC and Africa WHO, the AFRA office, are now working. They have an agreement. They're working very strongly together to try and get access to the vaccines. And we're starting to see the Mpox vaccines. Certainly the first country was obviously the DRC, with the outbreaks the largest, but we're hoping to get the vaccine soon. As you heard from the SAHPRA point of view, that's in the process. That's been approved by WHO. Marburg, so far on that question, the Marburg outbreak is confined at the moment to Rwanda. Marburg is a very nasty virus, and it has a very high mortality, or over 30% mortality rate. So far, we don't have vaccines or therapeutics or good diagnostics. And this has been fast-tracked now by WHO. And in fact, there was a pre-approved, from an ethics and a design point of view, trial design, a protocol for Marburg products, but particularly for vaccines, by the World Health Organization. And they're working closely now with Rwandan scientists to as rapidly as possible, getting some of, particularly the vaccines in the early phases of development into the field for larger evaluation. The issue of, I just wanted to add one thing, and we mentioned it when we were in Cape Town, but I think it's very important, is as with any piece of new legislation, as we look at it now, the SAHPRA legislation, one of the biggest problems we're finding is that it's been amended. The Medicines Act has been amended and amended and amended, and it makes it really difficult. So we have a committee now that's looking at the legislation and is looking at how do we smarten up this legislation so it's much easier for people to read and interpret, and that we have a consolidated new piece of legislation that takes into account many years of repeated serial amendments. So we will obviously be coming back to you on that matter. I think the other thing I would just say, I mean, I think there's a lot of interest in access and emergencies, is that we now have an emergency committee of the Africa CDC, which I'm a member of, and there's also an emergency committee for the African WHO regional office, which I'm also a member of, and both of those are actively looking at all of these outbreaks that are occurring. And I chair the vaccine committee for WHO in the African region. So there's a lot of activity in response to access to products, the relevant clinical trials, getting research out quickly, and sponsorship of products. But I do think it's worth through yourselves, really keeping the pressure on through the AU about the need for improved access to all of these products. I think the other points have been responded to. Thank you.
No, Prof, I did not hear any comment with regards to, you do have external funders, how much is that?
Oh, yes.
There was one asked by Honorable Motubase, please, thanks.
Yes, no, that and that I recall also came up as a big question when we were in Cape Town. So we do have a number of international funders, and some of them will be very specific. I'll ask the CEO to quickly go through and tell you. So many of them are either philanthropic or they are global health funding agencies, such as the Global Fund. And they will be then, if they are a global funding agency, they'll be quite specific for the area of work that they will support. But there's a huge growing recognition that of the importance, particularly post-COVID, of regulatory authorities, and that many, many regulatory authorities are getting international support, many in the African region. For example, the Bill and Melinda Gates Foundation are funding many African regulatory authorities, simply because, as you've heard here, I won't say, I don't think regulatory authorities per se, I wouldn't say that they're expensive, but they are often in our region underfunded for the jobs we're asking them to do. And the jobs we're asking them to do have grown just incrementally over many years. And the complexity of what we're asking the regulator to do has also grown. So we do have a number of international funders, but I'll ask the CEO to give you the specifics, and you'll see that some of them are specific for what the purpose of that fund is. We do not take funds from the pharmaceutical industry, because that would obviously be a conflict of interest. So these are funds that are not tied or cannot be seen as conflicting with the role of the regulatory authority. Every fund that you get, every donation that you get, will be for a specific purpose. It won't be, you just won't get sort of, well, we're giving you this and you can, you know, put it to what you want. You have to say, we want to strengthen A, B, or C. And this is what we are requesting funding for. So it will be very circumscribed to a set of activities that you will then report on. CEO, would you like to just give some specifics?
Thank you, Chair. Yes, I'll give an example. You're absolutely right. But we've also put in place is a policy for receiving grant funding. And this is a policy that's approved by the board. And the principles within that is that we must never have a funder influence what it is that we do. We must not ever get funding from any entity wherein there's a conflict of interest. So those are some of the principles in there. I'll give an example with, say, Global Fund. So Global Fund, many of you will be aware, they support a number of initiatives at a country level. And the funding actually is directed through the National Department of Health. They've got projects, for example, where they're supporting our medical depots. And about a year plus ago, we approached them and we asked for funding for, I guess it's two main areas. One is for assisting us with the human capacity, so being able to fill some of the roles on contract so that we can then release some of the SAHPRA funding as we generate more revenue. The other activity within that would be project management type support and our digitization efforts. So they don't tell us, and they always say this to us, that they can never tell NRAs what it is that they want. We tell them what it is that they want, and they then fund those initiatives. Another one, as I mentioned, it's the GIZ. So what I've just referenced is the Global Fund. It's GIZ, it's part of the government, the German government philanthropic arm, and they're supporting a lot of our digitization work, as well as helping us develop training material so that we've got staff internally who can train others as we recruit staff members. And again, it's a need that we have. And as I've indicated earlier, and I think the CFO also referred to it, that we do report on these in our annual financial statements. We report when they provide us with the money directly into our bank account. and even when the support is in kind. And so all of those details are provided, but we have to ensure that we comply with our policy. And again, we give feedback to the board on this funding on a quarterly basis. Thank you, Chair.
Okay. No, if then you are done, Chairperson, thank you very much with that. We would like just to encourage you through what has come up here to also to have a focus and attend to these staffing issues. But we want to commend you very much for continuously getting good audit outcomes. They actually would be something that even the Department of Health would learn from you, how we are doing it. And we want to really encourage you to keep on that part. Your global footprint is highly appreciated, and please don't lose that part, because then you become a very powerful force in the world, especially on behalf of the Global South, on all these issues that are really happening all over. We would then hope that you have covered most of the things. You are there. Of course, you are very honest to say, yes, we have done so much, but there are certain areas which did not achieve that within your plans, and we appreciate that. We then want to release you and say thank you very much for sharing with us your performance and the report that we have just tabled. Chairperson, Professor Rees and Dr. Semente, the CEO, and the whole team, we really want to thank you and then release you now. Have a good day.
Thank you so much. Thank you, Honourable Member.
Thank you, everyone. Bye-bye.
Bye-bye.
Thank you. Hi.
Honourable members, we would have an early lunch. And because I'm very generous this time, can we have it 1 to 2? Because we've done very well. So we meet at 2 o'clock and start. I hope Dr. Tembekwa is going to buy me a bunch of flowers, because I've allowed a whole hour and 5 minutes. Even. Maybe we could leave it at that and be seated, honorable members, by 2 o'clock. And then Dr. Ms. Machalamba and the team from Ombud, I know he's here already, our professor, please log in and test before 2 o'clock, so that at 2 o'clock we start immediately. Enjoy your lunch, honorable members. See you and speak to you at 2 o'clock. Thank you.
Thank you, Chair.
Recording stopped. Recording in progress.
Okay. Good afternoon, honorable members. Back from our lunch. I hope you did have a bit of a break and a relaxation, stretch your legs, move around. And now we are back on the last leg of our day's deliberations. We welcome the Ombud person on the platform. Welcome to you, Professor. We would like to give you this opportunity to present. At least we know you, we have seen you before. Mainly the focus is what has been the contribution that you have made in terms of the report that was there, in terms of the plan that was there. Against that, you report progress. We now give this platform over to you, to Professor Ombudsperson. Thank you very much.
Thank you very much, Chair. It's an honor and privilege for me to present our annual report to the committee. Yes, indeed, we had met about a month or so ago when we were introducing ourselves to the committee. So I'm not new, and my voice is not new, as well as my presentation will not be completely new. But I will go through some updates as we proceed with this presentation. I don't know if the secretary is able to share my presentation, which was sent to her.
Ms. Machalamba. Ms. Machalamba, was there such an arrangement that you will flight the presentation for Prof?
If not, Chair, we'll do it ourselves. Although I'm technically
there you are. Somebody might have come to your rescue, Professor. You have that one was a better arrangement. The first one was better than this second one of showing two slides. Who is operating the slides?
It's myself, Chairperson.
One slide at a time.
I'm trying to do that, Chair.
You got it right and you changed it yourself. Don't change anything now. You got it right. Thank you.
Once again, I should thank the committee for giving me the opportunity to present the annual report of the year ended. And next slide. The outline briefly that I'm going to just mention briefly the enabling legislation, and then the work process that the office is following. And then, as I said already, that we'll present the throughput and then update it up to Q2 of the current financial year. And then we'll talk about the national preventative mechanism, participation, the appeals against the findings of the Ombud, some key interventions to be implemented, and then give us a summary at the end of the financial year that ended, as well as our future plans. Thank you. Margaret, thank you. I mean, you must advance the slide. The guiding legislation is the National Health Amendment Act, and we follow the procedural regulations pertaining to the function of the Office of the Health Standard Compliance and the handling of complaints by the Ombud. And we use the norms and standards regulations that are applicable to different health categories of health establishments, as well as being guided by the Protection of Personal Information Act, Promotion of Access to Information Act, and underpinned by the Promotion of Administrative Justice Act. Thank you. Now, the guiding principles of the work of the Health Ombud are that the purpose is to investigate and conclude on the complaints in a procedurally fair, economic, and expeditious manner. I underline expeditious because up to now, we have not been able to do our work expeditiously for reasons that I'm going to illustrate later. And we can also start investigations on our own where there are suspicions of infractions of norms and standards. Our output measure is the mediation between the complainant and the health establishment, and to remediate of the defects within the remediation of the defects within the health establishment, and above all, a recommendation for health systems improvement or overhaul by government. The expected outcomes is ultimately improvement of quality of healthcare services rendered to the citizens of the Republic. Thank you. The work process of the Health Ombud comprises two distinct but interrelated units. All the 32 staff within the complaints management program, which is the Office of the Health Ombud, are seconded from the Office of the Health Standard Compliance. These units are, one, the complaints call center, which registers all complaints received and deals with and concludes low risk complaints, and then refer the medium to higher risk to other units. And the second unit is the assessment unit, whose duty is to analyze and assess and conclude medium risk complaints. The third unit investigates high and extremely high rated complaints. The legal unit, it also investigates the high risk and extremely high risk rated complaints, but also supports the Ombud with the legal advice, as well as attends to the national preventative mechanism in investigations or inspections. Thank you. Perhaps it is good now to come to the definitions of these risk rating. A low risk rating is where the complaint involves no harm to patients, nor staff, nor visitors. The medium risk is where the complaint involves a limited complications to the patient from treatment, but that complication requires no further treatment. It also involves where a member of staff or a visitor was injured and required treatment with loss of time or restricted functionality. The high risk is where the patient suffered harm during or as a result of treatment, which resulted in hospitalization or increased hospital stay, or where permanent injury was caused to a member of staff or visitor with loss of capacity. Extreme risk involves where there's a death of patient or visitor or member of staff. Next. How we should look at the throughput over the years. We'll note that we've got 5 completed years, and then the last bar there is the two quarters of the current financial year. You will note that there was some increase until the financial year 2021-22, which was at the peak of COVID. And then there's been a decline, a steady decline to more or less the levels where the prior years were. And at the year to date, it shows that we will probably end up at more or less the same level as the last 2 financial years. I might just comment that the peak that we saw during COVID were not related to the infection of COVID per se. Thank you. Next slide. This slide shows the distribution of complaints received by province. By far, the bulk of the complaints come from Gauteng, which is the deep blue pie, and then followed by the Western Cape, the lighter blue, and next by KZN, which is yellow, I think. And these, in the main, reflect the proportion of human density in those provinces, but also, as it will show a little later, that most of the tertiary hospitals and higher level of hospitalization occurs in those three provinces. Next. This slide shows us the severity of the cases that have been received, and it is noted that by far the majority are low risk, as defined, followed by medium risk, and massively the extreme risk is also very rare. Thank you. This slide here just repeats what we've just seen, but putting it into perspective. And the first bar are the total number of cases received over the previous while, and that only 9% are serious enough to be referred for investigation. And of that 9%, by far the majority, about just under 18%, just over 18% are solved at the assessment center. I need to explain that the assessment center actually does not do investigations. They don't do physical investigations. They do desktop investigations. They call for all the evidence. And if the evidence is clear, then they make the decision. And remember that this is where the complaint involves either complications that are not that serious, that do not require hospitalization. And the last bar shows those that are serious enough to require investigation, and they represent 1.8%. Next. Thank you. This slide here shows the performance of the different units, and let me say the next few slides are going to show the performance of the different units, and the slide that we are looking at now shows the performance of the call center. And the target for the call center currently is that they should be able to conclude 85% of the cases that they do see. And we can see that over the years, they've been improving in their performance. And indeed, in the current year, reporting year, they exceeded that target. The target was 85%, and they performed at 96.6%. And for the 2 quarters of the current year, they are performing at 92%. So we anticipate that by year of financial year end, that they will again exceed their target. Thank you. This slide shows the performance of the assessment unit. Now, apart from the first bar, which was the financial year 2018-2019, the unit has been performing steadily. the performance has been steadily improving, but still not reaching the target of 70%. And even when we look at the year under review, they attained 54% as against 70% target. Hopefully, if we look at the current financial year, the first 2 quarters of the current financial year, they are performing at 69%. So we hope that this will, for the first time, lead to them reaching their target. I need to comment that the Health Ombud was given some extra investigators in the current financial year. So that's why we hope that the performance will be sustained. Thank you. Next. Now, this slide shows this slide and the one following. It shows the performance of the investigation unit to remind the honorable committee members that the investigations are those complaints that are high risk or extremely high risk rated, where either there was injury that required hospitalization, or a complication that required hospitalization, or prolonged the hospitalization as a result of treatment, and the extreme rated where there was death. Now, you will see that before I say it, you will see the target is 20%. So over the years, we have not met the target, except this year under review. In other words, the reported year, where we attained 21%. Now the attainment for the two quarters of the current financial year is just under 43%, and that is due to the extra personnel extra investigators that were appointed the last financial year. And I need to point out to the committee members that these complicated cases, they take upwards of 6 months. So by the time you finish the investigation, 6 months, in other words, there's a lag. The cases that you start this year, a number of them will be completed by the following reporting year. Next. Thank you. This is a busy slide, but what I do want to point out, it relates to the treatment of women. And we chose the women for 2 reasons. One is that when we put this report together, it was September, which is a Women's Month, but also that the acuity, the seriousness of the complaints that we do get, a number of them relate to women. Therefore, in the slide, I don't have a pointer, so I can't lead you to the facts. But if you look at the third row, let's start with the second row, that just under 6% were the complaints related to women. We're talking about complaints that that were serious now, and of those, by far the majority were against public institutions, and then the reason for the complaint was mainly clinical mismanagement pertaining to the peripartum and perinatal complications or deaths. Thank you. Next. Now, we said that the majority of the complaints are against the public health institutions. Now, if we break down the categorization or classification of the public health institutions, the majority are against the public health clinics, and followed by the district hospitals and then regional hospitals. This is not entirely surprising because those categories, they are the most plentiful in the country. Next. This slide, maybe I'll go through it a little bit slowly. The heading is not quite correct. So the heading is that it shows 10 health establishment ranked by the highest to the lowest number of complaints that required investigation. I repeat, it shows that the 10 highest number of complaints from health establishment ranked from highest to low of complaints that were serious enough to require investigation. Now you will notice that the number one is Chris Hani Baragwanath Hospital, followed by Steve Biko, followed by George Mokare, followed by Charlotte McClurkin at number 5. I skipped Tembisa deliberately, but that shows that most of the serious complaints or cases, they derive from central hospitals. And then they are followed by tertiary hospitals like Tembisa, Helen Joseph, Calafo, and now this shows that, as expected, the serious complications come from tertiary or higher institutions which deal with most complicated cases. Now, you will also note that all of them come from Gauteng. Next, thank you. Next. Now, this slide attempts to break down the kind of cases of that come from the private health institutions. It shows that the majority are relate to medical aids, and indeed they are not within our mandate of investigation. And then after that are the private hospitals and then medical centers and so on. Next. This slide shows the kind of cases that are presented from the private health establishment for the period. And we will see that the majority are accident and emergency, and the most sorry, let me start again. The majority is general, followed by accident and emergency, followed by the internal medicine. But the most serious, which is why we put it first, are gynecology and obstetrics. Next. Now, if we look at the private health establishment by group, we'll see that Netcare receives most number of complaints, followed by Mediclinic and Life Care and so on. Now, before we think that Netcare or condemn Netcare, is that Netcare is by far the largest of the private hospital groups, followed by Life Healthcare, and then closely by Mediclinic. In other words, I don't want us to have to go away with an impression that the different hospital groups perform any worse than the others. But this reflects the number of beds that they do have. Next. Now we turn to the National Preventative Mechanism. And this National Preventative Mechanism is an instrument of the United Nations OPCAT. OPCAT standing for Optional Protocol to the Convention Against Torture and other cruel, inhumane, or degrading treatment or punishment of individuals whose liberty has been curtailed or deprived of liberty. Now, under the OPCAT,
excuse me,
yes,
just to improve your pace, because we are not doing well on time. Just improve a bit on your pace. Thanks.
Thank you. In any case, the OPCAT has got this national preventative mechanism. But the next slide. South Africa has opted for a multi-organizational mechanism, which includes the Health Ombuds, among others. But the government did not vote any funding for the National Preventative Mechanism. So the individual institutions have got to find money from their own resources. And for that reason, my predecessor, because there was no money, he did not join the NPN for about 4 years. But we think that this is not an option, so we've done that. And the next slide shows, next slide, that since August of last year, we've attended five inspections, and out of that 5, there were 8 psychiatric facilities whose inspection requires our specialized expertise. Next. The slide shows that there were a few appeals against the decisions of the Health Ombud, and out of the 4 appeals that have been adjudicated, 3 were adjudicated in favor of the Health Ombud. And the one that was not adjudicated in our favor was on a procedural basis that we should have given the complainant a grace of investigating it, although the complaint had surpassed the maximum period of 2 years. Next slide. Now, the key things that we need to implement is mainly human resources. And why do we need more additional investigators? One, we need investigators for the NPM mechanism participation. And then two, we need to appoint a temporary, let's say, appointments to deal with the legacy backlog cases. And of course, we need more investigators, because our cases, although the total number of complaints is going down, the acuity is increasing. Next slide. This next slide is important to us because we think that, not that we think, we know that the law expects the Health Ombuds to be independent, and yet the current legislation puts it within another institution, which is the OHS. So we would want to amend the legislation so that the Health Ombud can be created as a freestanding entity, and also would require the Health Ombud to have a mechanism of enforcing their and monitoring their recommendations. Next. I'll skip the slide because, as highlighted there, the Office of Health Standard Compliance has identified suitable office spaces slated to be occupied by March 2025. Our office cooperates with other organs of state. Already mentioned the NPM, but we've also joined the Public Service Commissioner, as well as the Department of Labor and Employment in inspection of the Doranginza Hospital. We also joined we are joined by the Public Health Commission and the South African Health and not Health, South African Human Rights Commission in the investigation of Helen Joseph. Next. Now, this is summary of what I've just said already. That I've just showed you that the complaints are decreasing in number, but their seriousness is increasing, and that Gauteng presents the majority of complaints, both private and public, and the public establishment presented the bulk of cases that required further investigations. Maternal and perinatal complications and mortality are the most worrisome, and there's an increasing backlog of high acuity cases due to shortage of staff in the first instance, and secondly, the inappropriate procurement procedures for medical expertise. I must just tell the committee members that we've got cases that are waiting for nearly a year to source expert opinion, but the adverts that have gone through a number of cycles have not attracted any suitable applicants. I've already told you that the number of appeals against the Health Ombuds are low, and those that had been adjudicated by the appeals tribunal, the majority were found in favor of the Health Ombud. This illustrates great achievement of the Health Ombuds Office during the reporting period, in part because of the extra temporary investigators that were appointed. And the last slide just updates some of the things that have been achieved in the year up to date, as well as the things that are still need to be done. Firstly is the appointment of permanent staff, thanks to the grant from Treasury that we received. And I've already said that we want a special project to deal with the legacy backlog, and we've submitted a request for 7.3 million for this. And then furthermore, we submitted a request of 5.9 million for participation in the National Preventative Mechanism inspections. We need staff to do research and data analytics to help to properly inform the health establishments and government on the priority areas that require improvement. We are going to continue to push for independence of the Office of the Health Ombud in the manner that I've already described by amendment of legislation. And we want to continue to grow international linkages with fraternal organizations, such as the Health Ombud presented at the International Ombudsman's Expo in August. Thank you very much. That concludes my input.
Okay, thank you very much, Professor Gwena. And we now going to request members to raise their hands, those who are in the platform and are able to do so. And let me then start recognizing in the following order. Dr. Vala, Professor, we'll come back to you. Yeah. Mute your phone for now. We have Dr. Tembekwayo as number 1, followed by, let me just see this one. Who's this one now hiding? Dr. Tembekwayo is now logged with 2 gadgets. Dr. Tembekwayo with 2 gadgets. Honorable Van Staden, number 2. Number 3 is Honorable Shabangu. 4, it's Honorable Dr. Leroux.
You missed me out, Chair. I was number 2.
Honorable Dr. Hosile Tape, number 5. Then we miss you. Then you come as number 6, Honorable Clark. I didn't see that. I was confused by 2 gadgets of Honorable Dr. Tembekwayo. Yes. Dr. Tembekwayo.
Thank you, Chair.
You have logged in.
My hand is also up, Chair.
This is, oh, Dr. Tembekwayo. Oh, sorry. Is that, I'm so sorry. It seems like it's Dr. Tembekwayo times 2 is Honorable Clark and Honorable Van Staden, Shabangu, Leroux. Let me see where your hand is not up as yet, but I'll put you, Honorable Sen. I don't see your hand here on the platform. So
and mine also.
Who's mine also?
Honorable Kumalo.
Okay. All right. Let me give you numbers again. Sorry, Honorable Clark, we pushed you down in the queue. 1, Dr. Tembekwayo. 2, Van Staden. 3, Shabangu. 4. Now, who's 4? 4. Shabangu.
Honorable Kumalo.
Okay. 4 after Van Staden.
Who is Dr. Leroux?
Shabangu, yeah. After Shabangu, then you go to Honorable Clark, Honorable Leroux, and then Honorable Clark, Honorable Seme, and Kumalo. Anyone left out? Yeah.
I'm being left out now.
Oh, that was your name. I skipped, yeah. Then you come after Kumalo. Sorry to leave you out. 1 is Dr. Tembekwayo start, Van Staden number 2, Shabangu number 3, 4, Honorable Leroux, 5, Honorable Clark, 6, Sene, 7, Kumalo, and Dr. Tape, 8. Thank you. In that order. Sorry to mix up your numbers.
Thank you, Chairperson. Can I start?
Yes, ma'am, you can.
Okay, thank you, and thanks for the presentation. I've got only 2 questions. The first question is based on the complaints that are sent through the call center. And then to say for an example, there's a complaint that is reported on Twitter and or on TikTok and other social media. How would you access such information? And secondly, how would your department be able to ensure that it's accessible to different audiences, including social media? And we know, all of us, that media attracts attention, and we can attest to the recent video that was circulating all over, the one that was sent by Tom London by over Helen Joseph's hospital about the saga of the treatment, of how the doctors maltreatment the patients. And the second question, the last one, is what efforts are made to inform the public, particularly in undeserved or rural areas, about the role and services of the Health Ombud? Thank you, Chair.
Honorable Van Staden, thank you.
Thank you, Chair. My question around the budget and office space were answered by slide 26. So I have just one question to the Ombudsman, and regarding your staff constraints. How does your office handle complex cases that require specialized medical or legal knowledge when you have a huge staff problem? And Chairperson, while I'm on the subject, we always, every year we say as a committee, we must give attention to this Health Ombudsman's problems regarding budget and office space, but I really think it is time that we step into this matter. Thank you.
Take it up very strongly with the ministry tomorrow. Thank you very much. Honorable Shabangu.
Thank you, Chair. Just a quick one. How does your office, your department, deal with failures of healthcare facilities, either private or public, to comply with Health Ombuds recommendations? And on your key interventions, Prof, you mentioned that you will be involving your NPM participation to address the disparities identified. We hope that when we meet again, we will be clarified on the interventions, because we hope this will be addressed, the problems will be addressed systematically by all the stakeholders, and then we'll see the impact. Thank you, Chair.
Thank you. Honorable Totoleru.
I just wanted to try my camera on. Thank you, Chair, and thank you for that presentation. I just wanted to get some clarity around some of the cases. I see that I was looking at the slide 9 where they talked about cases that have been over the last 10 years from April 2015 to March 2024. And I mean, there's obviously lots of low risk cases, but the ones that take most attention and time are the ones that are high risk. And there's 181 high risk, medium, high, and extreme risk cases over 10 years, so about 18 a year. And I think that those are obviously, in this analysis, I think for me, the low risk cases are important to mention, but I think that when we do the statistics, it is important for us to get a sense of how many high-risk cases are at each facility and in each province, for example, and also in the private sector. So I think I would want to request that we get that data specifically around the high risk, medium, high, and extreme risk cases, and we get a breakdown of that, because I think that's very important for us to see. And then the second thing to say is that I just see that there's a particular concern expressed around maternity, and and again, we see a lot of the Gauteng hospitals being on slide 16 being involved. But what kind of recommendations and what kind of feedback do we get to the departments of health nationally, but also to the provincial departments of health around those maternity cases, because we obviously, that's one of the areas where we're trying to improve, and it seems like things are getting worse. So I'd just like to get the Ombud's perspective on that and ask how that can be fed back to the provinces and to national, and how we can actually get proper recommendations about how we can improve things there, because we really, if we can't look after our pregnant mums and our babies properly, we are failing as a society. Thank you.
Thank you. Honorable Clark.
Thank you, Chairperson. Yes, look, I agree with you. We really need to we've been speaking about this for a long time. We really need to take this to the ministry so that the Ombudsman can actually do justice to what they need to be done. And I 100% agree with the Ombudsman that they should become an independent body with their own powers in order to do justice to what they're doing. I also believe that most of these complaints are in Gauteng, so that really alerts the necessity for us as a committee to go and do oversights at those hospitals. And then my question is to the Ombudsman, how much staff do you think you would need to be fully capacitated? And considering the staff constraints within the OHO, how does the office handle particular complex cases that require specialized medical and legal knowledge? And what mechanisms are in place to ensure that the health facilities implement the Health Ombuds recommendations? Thank you, Chair.
Thank you very much, ma'am. Honorable Sen.
Thank you, Chairperson. My first question is almost similar to that of Dr. Tembekwayo. How is the Ombud utilizing digital technology such as social media and WhatsApp to improve public awareness of patients' rights and accessibility for patients to lodge complaints? What steps are being taken to raise public awareness about the role of the Health Ombuds and the process of lodging a complaint? And then my last question, Chair, is what specific interventions are considered to strengthen the knowledge gap and accessibility in rural and marginalized communities? How are the language barriers addressed in this regards? Do you have translators? Do you have interpreters as well to assist our people who are especially from our disadvantaged areas? Thank you very much, Chair.
Thank you, Honorable Kumalo.
Thank you very much, Chair. Good afternoon to everyone. Chair, I'm having only two questions in relation to this matter. One, what other factors does the Ombud assign to the decline in complaints? What correlation does the Ombud draw between decreased complaints and the delivery of healthcare? Secondly, Chair, are the mechanism in place to track the demographics of patients who lodge complaints, enabling the identification of specific groups disproportionately impacted by particular healthcare challenges? How does this data inform targeted intervention to ensure equitable access to health care across all demographic groups? Those are my questions, Chairperson. Thank you.
Thank you, Honorable Dr. Letlap.
Thank you, Chair, and thank you, Prof, for the presentation. The first question just follows up on the issue of recommendations, remedial actions, non-compliance, and what are the next steps that happens in relation to that. And the issue of lack of expert opinions to help you conclude matters. Is there any plan about compulsion of our academic sector or experts out there in terms of jury duty to help with that? Because it's the same challenge even with the Health Professions Council. The next question is about what is the proportion of complaints from foreign nationals, given the high numbers of foreigners using our maternity service, and that some of the complaints would come from reproductive health services. And then the last question is, in terms of independence, which we support and I support, given the austerity measures from government in terms of funding of institutions, is there a concept of shared services while maintaining independence so that you can save on costs? Is there negotiation about staff transfers to yourselves, because a lot of the staff that you have are seconded from Office of Health Standards Compliance? Do they go back home or do they stay with you and the budgets be given through to you? Thank you, Chair.
Thank you very much, Chair. Dr. Letlap. Professor Mukwena, the report that you have given mirrors the presentation that was made by the minister when he was supported by Advocate Motibi, in that the volumes of complaints or of medical legal cases are coming in from the province that you have mentioned, except that there's an outlier here, which is really a problem, that it doesn't really include Eastern Cape, and yet when it comes to medical legal claims, it's one of the top. So there's a bit of some similarities there in terms of those, and it will help us to understand whether you do share this. Is there any platform where these volumes of complaints, of course, some of them you are really raising them coming in from maternal and child health, you raise them with the minister, and what is the level of interaction and resolution thereof? you also would need specialized staff sometimes to support you on your work. Are you finding that being possible to do? What strategies did you use to plan on your unannounced visits that you are going to go left or right, and how did you find that helpful? What can you learn from that and or share with us? Do you think you have a backlog? I can't remember whether you presented this slide. Maybe there is the backlog of what has been brought to your attention that you have not managed to really attend to as complaints, the volumes. If you could then assist us, Professor, with those responses, we'll appreciate. Thank you very much.
Thank you very much, Chair. I don't think I'll be able to remember everything that everyone said, but I'll try my best. If we start from the beginning.
You mean you didn't have a pen and paper?
Yeah, but I'm an old man. I can't write that fast. If we address Honorable Tembekwile about access of complaints from social media. Yes, we scan the social media, but we also have to filter the noise from the real issues. In the main, people who are actually aggrieved, they are able to access us via a number of platforms that we do have. I might just say that one of the things that we are trying now is to use WhatsApp. The young people, they call the WhatsApp chat box, but we are still working on that. We are yet to pilot it. But otherwise, we scan the media for the serious things. The name of Tom London, whose real name is Thomas Holmes, we are on top of that. We are investigating that as we speak. But in part because these videos, they showed some preliminary evidence that there's something serious there. Now, the way we've informed the public, especially the underserved, I think this also was asked by Honorable Seme, so I'll handle those together. Is that we have radio shows, and also we have outreach programs where the office goes to different locations, and I think this month we'll be going to Northwest, among other places where we do publicize the work of the Health Ombud, as well as the work of the Office of the Health Standard Compliance. And then we also take the opportunity to present on television. Usually we get invited, and then we take advantage of that to publicize our activities. Honorable Van Staden was asking about how do we resolve complex cases given the staff complements. we try our level best. However, it is because of the complexity of the cases and the constraint of staff that we are building up. Building up backlog cases, and I can't remember off the back of my head now how much backlog cases we've chalked up in the year under review, but we have about 198 backlog cases, and although we are solving some of the older ones, new ones are coming in, precisely because of the shortage of staff. And then you Chair, in that regard, you asked about expert opinion, and Honorable Letlape also referred to this. Honorable, the expert opinion, because of the complexity of the cases, we have asked retired academics to assist, but I think that's not fair. And then we have also asked current academics that are still active. However, that's not a good solution, because many of the cases, they may require expertise that doesn't reside on full-time staff of the academics. Some of you may know that a substantial number of academics are actually private. In other words, they are part-time appointments by the universities, and they have their own private practices. And therefore, it's difficult for them, as a result, to answer. They don't answer the call for to enroll as expert witnesses, not witnesses, expert opinion, to give us expert opinion. And then the Honorable Shabangu was asking about how do we enforce the recommendations of the Health Ombud. The law doesn't talk about enforcement, it talks about monitoring. And it places the monitoring at the door of the CEO of the Office of the Health Standard Compliance. And that office has got its own work cut out for it. And they don't have the personnel to monitor necessarily. However, part of our recommendations is that the health establishment should give the Office of the Health Standard Compliance CEO reports on the progress of their compliance, and by default we also then get to be given. However, the ability to go and monitor those that do not on their own give us the updates. We don't have personnel to do that, except for those that are very, very high risk or high publicity. Then we follow them up. By we now, I include ourselves with the Office of the Health Standard Compliance. Now, the Honorable Shabang also spoke about intervention in the NPM. The NPM does not really fall on our office. The coordinator of the NPM is the Human Rights Commission. So our findings, they become part of a larger report that is coordinated by the Human Rights Commission, and then it is the Human Rights Commission, through their own processes, that see that our recommendations are enforced. Up to now, we haven't had an occasion to find out what enforcement they have undertaken. And then Honorable Leroux wants us to break down this serious cases by province and by public and private. It is possible to do that. We haven't done that yet, except for those that are very glaring. In other words, it's not a breakdown. It's just that we do know where the most serious cases are. But that would require active analysis. And we don't have staff to do that. As you recall, in the presentation that I've just given, I said that we need researchers that are going to do exactly what you are asking us to do. And the feedback about maternal and perinatal complications and maternity, we discuss those with the Minister of Health. It is a requirement that the Health Ombud and the Minister have a quarterly meeting, and in those quarterly meetings we talk about this. However, we are now trying to get to the bottom of the nodes. We know the pattern, but we don't know where exactly these maternal and perinatal complications and deaths are happening. And I've asked my office to assist to do that, but they don't have the knowledge and the manpower to do that kind of analysis. So we need more people. Honorable Clark, thank you for supporting us about independence and the need for staff. Now you ask about how much staff do we need? We haven't done a needs analysis in a manner. However, when we were asking for more money from Treasury, we said that we need at least to double the number of investigations. We have investigators, we have 9 currently. So we need another 10 investigators in order to do this. This is quite apart from dealing with the backlog that I said that we need a special project to deal with the legacy backlog. And then about the enforcement of the recommendation of the Health Ombud, I've already answered in part when I was answering Honorable Shabangu, and that the law doesn't actually give us enforcement powers. It gives the office of the CEO of the Office of Health Standard Compliance, the monitoring and the monitoring duty, but not enforcement. And then, Honorable Kumalo, you are asking about demographics of complaints, and then something else. But let me start with the demographics of complaints. We have not analyzed the demographics in terms of who, what class, what race, and what we know is where they come from. So we haven't done that analysis, and perhaps with sufficient resources we could do that, and then maybe also to because you wanted us to talk about how do we target the vulnerable, or what you think the underserved. I could combine that with the question from Honorable Sen, is that we see that there are fewer complaints from the rural provinces. So we try by all means to go to those provinces and use the community and the public radios that are used in those communities to make them aware of our work. And then Honorable Letlape was asking about non-compliance. What do you do about non-compliance? I think in the main, we've answered that we've got no powers to enforce non-compliance. Ours, though, if I could just step back, is that I don't think the creation of ombudsman was envisaged a punitive type of activity, but rather a mediation and promotional, that the health establishments that are non-compliant, we try to make them compliant by just pointing out what they need to do and how it is good for them, as well as the public at large. Of course, the public health establishments, I'm sorry to say, some of the managers are indifferent, and therefore very difficult to persuade them. But I said some. But most actually do comply. And the expert opinion, I think I've dealt with the expert opinion, but you're asking, can't we force academics to do that? I've been an academic for a little long time than most people. If you force academics, then they won't do it. They will kick you to touch. But most of them, they cooperate when we need expert opinion. We've just had one pediatric intensivist give us an opinion when one other had turned it down. However, no, let me just say that I do not envisage us forcing someone, compelling people. We can coerce, but not compel. And then you are asking about foreigners and the use of our maternities. When we capture the complaint, we do not capture what the whether the users are foreign or not. We only capture the institution that they come from. I don't know if we would really want to do that, because I think that might in fact affect our impartiality. But if you as politicians you want that, it's not difficult to get that information via other means. The hospitals would know who's foreign and who's not foreign. And then the question of shared services. The Treasury and I have spoken about the shared services, but I think our conversation was a year ago now, but we haven't moved it, in part because this is what the Department of Health was saying, that things were put at abeyance until the current what do we call it now? The 7th administration is in place and running. So we're going to pursue that in the next quarter or so. And then there's one question that I missed of Honorable Kumalo. But Chair, you're asking about interaction with the ministry. We interact with the ministry, as I said, on a quarterly basis, and we share our reports with the minister. And the minister, like for instance, in terms of the maternal and perinatal death, we've agreed that we are going to drill down and identify the nodes, if any, where these come from. Remembering, though, that there is another process of the confidential perinatal, maternal and perinatal death inquiry. But the two are not mutually exclusive. One can feed into the other. And then the unannounced visits. The unannounced visits, Chair, they are done only by the National Preventative Mechanism. When we investigate, we tell the health establishment ahead of time, because by the time we would have investigated, we would have sought clarification regarding the complaint that is lodged with us, or whatever it is that we pick by other means. Like there is an early warning system that we practice by scanning, as I said, the public media. And then once we decide that we are going to take step, we forewarn and ask the institution questions before we go and deal with them. Now, the backlog, I think we have addressed the backlog, but I will repeat so that I can I should elicit your assistance as parliamentarians and present us to Treasury. We think that it's important to deal with this backlog because some of the backlog dates back to maybe 6 years, 7 years, and that the complainants may have even died, but or the persona dramatis, the health professions that were involved, some of them have died, or they've emigrated. A number of doctors, particularly, and nurses, they leave the country and go and work in other places. So it's important to deal with the backlog while people are still alive and of able mind. So the mechanism that we have proposed, I repeat myself now, is a special project that will last a year to 18 months by our estimation. And then let me ask my colleagues here if I've left out any question. Or the language issue. On the language issue, we've got people that among our staff, there are people who speak all the languages of this country. So when a complainant is conversant in one particular language, we assign that to the investigator that has competence, if not fluency, in that particular language. In terms of our outreach and so on, I've already mentioned that we use the communal radios that the population is being served by, and when we do that, we use the local language.
Okay. Thank you very much, Professor, for your response.
Thank you.
Yeah, we will take up their support that you are raising, but it gives us comfort when you say you do get to do quarterly meetings with the minister. So we will be raising things with the minister for the first time, because you yourself, when you get a space, you do raise the issues of your staffing requirements. And for us is to add on, you won't be hearing it for the first time. We have an easy access to the Minister of Health than the Minister of Finance ourselves. I'm glad you mentioned the issues of the National Inquiries into Maternal Death Reports, because that is a triennial report. There's just been one release now. It does give you a bit of a demographic space where these maternal deaths will be coming from, which provinces, sometimes up to which hospitals within that province. So I think that also could be one of the resource documents that could actually support your endeavors going forward. But we will continue valuing your contribution. And thanks that you have taken up this issue of national prevention mechanism forward. And you do have our support. And the Honorable Clerk did raise, we'll raise with the minister. But we hope that you'll be raising with the minister things that you have already discussed with him anyway, that you also do have pressures in terms of wanting to get and improve your staffing. Okay. With that, Prof, we would like to then release you or stay behind and hear whether Dr. Mdaweni and her team are supporting you in some of the things, but we want to thank her for actually seconding about, you said 32 staff members from her space to support your work of very important work that until and unless you are getting enough staffing, she's going to borrow you some members, and we appreciate that, Dr. Mdaweni. We will then take a 5 minutes break for Dr. Mdaweni and her team to log in and prepare for the presentation that is coming now. Thank you. Thank you, Prof, and have a good day.
Thank you, Chairman. And thank you to your committee. Thank you very much.
Okay. Okay. Good afternoon, Dr. Mdaweni. I did not notice whether the chairperson is also here. You could then take on the platform and introduce the leadership of the Office of the Health Standard Compliance. We have had your input about a month and a half ago, so we're a bit familiar with what you are up to. And this presentation also came to us. So it's mainly to get us to be updated about how have you been performing against the plan that you tabled to this portfolio committee some few months back. The platform is now yours, Dr. Mdaweni, or the chairperson of the board, whoever leads that.
Good afternoon. Good afternoon, Chair and Honorable Dr. Dlomo. Good afternoon, members of the Health Portfolio Committee. I am Dr. Ernest Kinoshi, the Chair of the Board of the OHSC. I think 10 out of 12 of us, we are members, there were 12 members appointed by the Minister in February of last year, 2023, for a 3-year term. And I think 10 of us have had confirmed attendance of this meeting. So some of my colleagues as board members would be in this meeting. I think we had 2 apologies, the Deputy Chair, Dr. Moral, and Ms. Palesa Santo. All the others would be part of this meeting. I must say we work closely with the CEO as board and the executive managers, but we also work very closely with the Health Ombud, Professor Bukwena, as we did with the previous Ombud. We do meet with Professor as board. We meet with Professor Mukwena on a regular basis, and I, as chairperson, also meet him on a regular basis as well to discuss issues, some of which he has raised, and he receives full support from us. And we, until it is regulated that the Office of the Ombud should be an independent body, which we also support. But until then, as board and as OHSC, will continue to give all the support that we, I think we can give at this stage. As has become traditional, Chair, we will ask the CEO to present on our behalf the performance of the OHSC as detailed in the annual report for 2023-2024, which is actually the performance against the APP of that year, according to the strategic plan that we have for 2024-2025, 2020-2025. So the CEO will present on our behalf of the OHSC, but when it comes to question time and comments, I think all of us will be involved. We'll assist the CEO as board members and other executive managers in responding and answering to questions of a number of members. Over to you, Dr. Mdaweni.
Thank you very much, Chair, and good afternoon to the Honorable Chairperson of the Portfolio Committee, honorable members, as well as the team from the Office of Health Standards Compliance. I would like to also introduce the executive team that is with us in this meeting. We've got all the heads of units in the Office of Health Standard Compliance, and also a good afternoon to the Health Ombuds, Professor Mukwena. We bring to the Health Portfolio Committee the progress and the outcomes of the annual performance plan of April 23 to March 24, I must indicate that as the organization, we were happy and pleased with the performance during the reporting period. We had a planned annual target of 23 targets that were in our annual performance plan. And out of this, we were able to achieve a progress of 70% towards achieving these targets. And we fell short by 30%, which was 7 out of the 23 targets. One of our goals and mission as the entity is that at some point, the work of the Office of Health Standard Compliance should touch the pulse of each and every person that visit our health facilities. This is captured in our vision of consistent, safe, and quality healthcare for all. Our mission, which defines our existence, is to monitor and enforce the safety and quality of all the services. And as we do so, we want to do this in an independent manner, and we remain partial and fair, and we act on behalf of all of the users. It is also important to indicate that there are a number of values which we all subscribe to that guide the work that we do. Most importantly is to respect each and every individual, being it a user and a healthcare worker that we come in contact with, and taking full accountability of the results and the outcomes from the office, and also remain transparent and open amongst ourselves and the managers as well as the employees. And integrity is quite important in that we remain honest and respect all the stakeholders that we get in touch with. One of the critical values is really doing the right thing, the right time, the first time around, which is the quality healthcare. The office is a jurisdict person established by the amendment of the National Health Act back in 2012, and also the procedural regulations, which defines how the Office of the Health Standard Compliance as well as the Health Ombud operates. One important piece of documents and legislation are the norms and standards that were promulgated by the Minister of Health in 2018, which are currently in use, and we use this to inspect the health establishments. Now, the Act confines certain duties to us. We are to assess and verify the quality of services by monitoring compliance with the norms and standards that are prescribed. And once again, as the Ombud has already indicated, they are within the Office of Health Standard Compliance in dealing with the complaints that he has gone through. We'll only be able to know the actual contribution and impact of us as a regulator in the healthcare sector when we start to see a reduction in avoidable mortality and morbidity, and a reduction in harm in all our health establishments during the provision of services. And it is also important to indicate that the overall impact will be the availability and the responsiveness, as well as the acceptability of our health establishments with regards to the provision of services. It is also critical to indicate that there are certain implications around our mandate. We act as the champion of the public and the healthcare users. And as we undertake our work, we would want to see a restoration of credibility and trust in all our health establishments. At the core of the right to health is the dignity of each and every person. We therefore say we respect all the health users, the families, as well as the healthcare personnel. It's also important to highlight that as much as we practice transparency, we respect highly the confidentiality of the information that we come across as we interact with all the health establishments. Now, the 2020 to 2025 strategic plan has defined 5 outcomes for the office. Most of these outcomes are around the establishment of the office. This national strategic plan comes to an end next year in 2025. Most of our outcomes will then look at some of the core outcomes and impacts in relation to the work that we do. I'm going to go through the next couple of slides where we'll go deeper into what was in the APP for 2023-24. We've got 5 implementing programs. Program 1 is administration, which provides cross-cutting support to all the programs. The biggest program is Program 2, Compliance Inspectorate, which houses all our inspectors. Program 3 is where is actually the Office of the Health Ombuds. Program 4 is where we develop standards, we conduct research, we also undertake in-depth data analysis and produce our reports. And the last program is certification enforcement. In the next couple of slides, I will go through the actual performance for the financial year. Our expenditure overall during 23-24 was 183,892,000, and we were at a vacancy rate of 4.5%, which then amounted to, at the end of the financial year, we only had 6 vacancies of the funded staff of 132 employees. I have already indicated that we are at 69.6 overall performance. This slide then depicts how all the targets are broken down per implementing unit. We must highlight that when we look at the previous financial year, which is 22-23, we were at 64%. We achieved 14 out of the 22 compared to 16 out of 23 for 23-24. And also of these indicators, the indicators that related to core program activities were 10 out of 16 achievement. In the previous year, it was 9 out of 14. The support indicators for 23-24, it was 16, we achieved 6 out of the 16, and in 22-23, 5 out of 14. So there is definitely an improvement from the previous financial year in terms of overall outcomes and performance. Now, going into each individual program and the related targets, for administration, the sub-program of human resources, the 6 blocks, the first block will look is what is actually in our strategic plan over the 5 years, the targets, and the last block will be the performance to date. We also have indicated the audited actual performance over the years for each indicator. We will, however, focus in the second block from the right, which is the audited actual performance for 23-24. Now, we wanted to have all the vacancies filled within 4 months from the date that they existed. For 23-24, we had overall 20 vacancies during the reporting period. We were able to fill 14 of these vacancies within the prescribed period of 4 months. We were interrupted by the moratorium on the filling of posts, which was a circular that was released by the National Treasury in the middle of the year. One of the other issues that we grapple with is that because actually most of the work that we do is quite specialized, we do tend to re-advertise quite a number of posts before we can actually get the candidates that will be able to occupy the posts. The percentage vacancy rate, out of the staff complement, the funded post of 132, as at the end of the financial year, we only had 6 vacancies, and we were able to surpass the target of 6%. We wanted to have at least a vacancy rate of less than 6%, and we were at 4.5. Now, we are required to train all our inspectors prior to them undertaking the inspectorate functions in all our health establishments. This is quite a comprehensive course which takes a number of months, and it is done in phases. And we were at the end of the financial year in 23-24, 36 of our inspectors were trained out of a staff complement of inspectors of 43, which gave us 83%. We just fell slightly short of the target of 95%. We have previously utilized a tertiary institution to undertake this training. We have since, through discussions with the board, are going to bring this training in-house so that it can be faster. But we also recognize that because the work is specialized, most of the capacity in relation to actually building the very same capacity is within the Office of Health Standard Compliance. We also monitored the availability of IT services for core services as well as overall support to the operations of the organization. We maintained the performance of 99% uptime during the financial year for both core services as well as support services. And this really was as a result of regular maintenance to address any system instability that may hamper or result in bottlenecks. So these two targets are the same. The only differentiator is that one looks at the core programs and the other looks at the overall support services for the organization. One of the important indicator is is community participation and community involvement. It is known as a best practice that in the offering of services, particularly quality services, we should involve the recipients themselves. Our activities have been focused on raising awareness around the role and the work and the functions of the Office of Health Standard Compliance, as well as the Health Ombuds. And to that end, we were able to conduct 25 community awareness activities over a target of 12. We're able to surpass this target because we undertook to collaborate with other regulatory entities when they were doing their outreach work. We also collaborated with the government communications and information system in some of the provinces. And also we've utilized other platforms like radio so that we can be able to raise awareness around the role of the OHSC and the Health Ombud, as well as making the public understand the importance of standards and also quality services in the health establishments. This target also relates to raising awareness, but this is more targeted at the private sector. And we had a target of 8. We were able to conduct 12 of these activities within the private sector. This is just a pictorial evidence of some of the work that we do. Here we indicate some of the interactions and engagements that we undertake with communities. And indeed, it is true that the focus for us and what we were actually told in one of the portfolio committees was to concentrate in the rural areas. And to that end, we conducted a radio campaign in community radio stations where we're able to raise awareness of this, of the functions of the two offices. And these are some of the interactions the Health Ombud held in terms of engaging the various platforms around the office as well as OHSC. We do participate in various platforms, being it conferences or any other platform where we know that we will be able to reach the public, and these are some of the pictures that depict the same. Honorable Chair and honorable members, we are pleased as the OHSC that since its inception, we have always maintained or achieved an unqualified audit opinion. This remains an important achievement for us, which we hope to maintain over the years. The OHSC board is committed to good governance and accountability for financial resources and any other resource, and also to ascertain that we are compliant legally with all the prescripts that govern the existence of the office. Now, coming to program 2, which is Compliance Inspectorate, this is a summary of the slides that I will go through individually. Now, the inspections that we conducted in the public sector for 23-24, we were able to conduct 734 over an overall 5-year target of 3,741. We managed to exceed the target of 689 by 46 inspections which were conducted. We are well aware that the 3,741 is a drop in the ocean when you consider the number of health establishments that we have in the country, which are in excess of 50,000 or so. When we set our targets for the financial year, we're always dictated upon by the funding pass which we have for the financial year. So the targets that we put are then aligned with the resources that we have. It is true that for us to make an impact, we have to do and conduct much more inspections than what we have indicated in this slide in the public sector. I must also commend the team in that to be able to reach these numbers, given the shortages of staff that we have, our team members had to sacrifice and conduct what we call back-to-back inspections, which means that they will be away for 2 to 3 weeks at a time out in the field and conducting inspections. Of course, this is not an ideal situation, but we wanted to reach the target. And also, as I've indicated, that it is because of the resource constraints. In our last sitting, we mentioned to the Honorable Committee that we have started inspecting the private sector. For 23-24, we had a target of 100. We were able to conduct 60 inspections in the private sector. We were affected by a reduction in staff. There's a cadre of staff which we appointed during the financial year, which we call them persons assisting inspectors. With the financial constraints, and these were appointed on contractual basis. We had to let go of this component because we could not sustain them because of our resources. I must indicate that even though we fell short of the target of 100, we have since recovered in the subsequent financial year, and we have inspected the 100 which was originally planned, but for the reporting period, we ended at 60 of the inspections in the private sector. Here we indicate the number of inspections for each province. They are really informed by the number of health establishments that are in a province. For an example, Eastern Cape, KwaZulu-Natal, with more health facilities, they will then have more inspections conducted. Here we show the various hospital groups where we indicated that we inspected 60 health establishments. The groups were clinics, Life Healthcare, Mediclinic, Netcare, and the National Health Network. Once we have conducted a routine inspection, we'll either certify the health establishment as compliant or non-compliant. When we have indicated that a health establishment is non-compliant, we'll then give them a notice of compliance. It would give them time to remedy the breaches in the norms and standards, but we will then indicate that at some point, we will go back to re-inspect that health establishment so that we can determine that there has been remedy in the breaches. So this indicator talks to the re-inspections which were conducted both in the public and private sector. We always put a target of 100% because once we have determined that a health establishment must be re-inspected, we would like to do so. I must indicate that for 23-24, we inspected 79 because of the shortages of staff, and we also indicate the provinces where we conducted the re-inspections. We also have a requirement that once we have conducted all inspections, we consolidate the findings, we conduct an in-depth analysis, we then produce an annual report, which will then give details of the compliance status as well as the findings in over the reporting period. We were not able to finalize this report by the end of the financial year, which was in March. Now, the reason being that it is stipulated in our procedural regulations that once we have given a preliminary inspection report, we must give a health establishment a period of 20 days for them to interact with our findings, and then they respond back to us. We have a period of another 20 days to consider their response, and we have another period of 20 days to release the report. I am stating this so that we can understand that the last inspections we conduct the very last month at the end of the financial year, which is March. If we've conducted inspections at the end of March, the 20-20-20 day rule is applicable, which always falls into the next reporting cycle. It's also important that we verify the data, and we also are certain that we have all the variables within the inspection findings before we can then produce a consolidated report. Over the years, this report has always overlapped into the next financial year. We also have to produce what we call biannual reports. A biannual report will then indicate all the health establishments that we have inspected in a 6-month period in terms of names and location and the status post the inspection. We were able to produce these biannual reports, and they are always put in our website after every 6 months, so that people can be aware of where we have been and also the outcomes and the findings of those inspections. Now coming to program 3, which is the Office of the Health Ombuds. Honorable Chair and honorable members, I am not going to go through the next 2 slides. The Health Ombud, Professor Mokoena, gave details in terms of the trend analysis of all the low-risk complaints that were resolved within 25 working days, and also which the provinces from where they came from. I must indicate that there's been quite a significant improvement in terms of the low-risk complaints. And similarly with the complaints that are resolved through assessment within 30 working days, Professor Mokoena also talked to this. And in the main, the reason why they fell short is because when it comes to this indicator, the team is always dependent on the interaction and the responsiveness of the health establishments, because once they have the information, they have to follow with health establishments and the complainants themselves. And at times, some of this information is received beyond the 30 working days period, which is in the targets. He has also talked to the investigations that are resolved within 6 months, where it was reported that the way a target was reached, 3 out of the 14 were resolved. Similarly, the next 2 targets will talk to the investigations that Professor Mokoena has alluded to. We must indicate that in the previous financial years, I think in the past 3 years, when we reported this indicator, it was always in the red. However, for this reporting period, because of the staff complement of 5 investigators that are on contracts, the team was able to shift the needle in terms of these cases, although still it is not enough. Now, this is also a different depiction of the resolution of cases. And this, again, it was addressed with most cases being from Gauteng and followed by the other provinces. We then come to program 4, which is where the standards are developed and where we conduct research and also triangulate the information from the inspection findings and develop what we call recommendations report. One of the most important functions of the Office of Health Standard Compliance, as it is stated in the Act, is that the board must advise the minister and the healthcare sector on quality assurance issues as well as management systems matters that relate to the provision of quality services. We had a target of 3 recommendations report to produce. 3 may look like a small number, but in order to develop these reports, you need to look at the trends and analyze data over the entire year. Now, the 1 recommendation report which we produced was for the Eastern Cape province, where we looked at the the early warning system data. We looked at their annual returns data. We looked at the media alerts, and we consolidated this information, and we're able to identify the gaps and matters of consideration and of importance that the two districts, Oliver Tambo and Alfred Nzo district in the Eastern Cape, should pay attention to. We then release this report to the province. We share it also with the head of department, and so that they can take this report, use it also to correct or to remedy or put systems in place for quality improvement in the entire province. We also produce what we call a national annual returns recommendation report. This is a report where we look at the profile of the hospitals in all of our provinces. The report will contain information such as, the catchment area and the size, also the services that are offered in the hospitals, the classification, the number of beds, the budget allocated and expenditure. Then we look at other issues that are very important, which will contribute as to whether that hospital is able to provide quality services or not, such as having backup electricity, whether they have running water, they have health information systems, they have security controlled access, they conduct patient satisfaction survey and self-assessment. Once all this information is then consolidated, it then assists the health establishment to determine where their areas of need are in relation to the provision of quality services. And these reports are disseminated to provinces, ushered, and they are also presented to them. We also produce what we call an early warning systems recommendation report. Now, in our environment, the early warning system looks at monitoring indicators of risks. By indicators of risk, we mean indicators such as when a patient absconds in a hospital, where there's act of harm to patients and healthcare workers, where there's probably a missing newborn, in the event radiological services are shut down, or when there's suicide of an inpatient. Now, with the early warning system, they are supposed to then report to us in the shortest possible time after an occurrence of one or two of what I have mentioned. Once we receive these reports, we then start our investigation in terms of to determine what could have gone wrong. But the most and the fundamental reason why we have this early warning system is so that we can prevent a recurrence of some of these incidences that happen in health facilities. We then produce this early warning system report looking at all these indicators for the healthcare sector. As much as we develop the tools based on the standards regulations to inspect facilities, we also have the responsibility to orientate the healthcare sector in its entirety on the utilization of the tools, the understanding of the tools, as well as to know and what to expect when we conduct the inspections. So we do this through providing what we call guidance support workshops with various stakeholders, and we have done so both in the private and the public sector. For 23-24, we had a target of 24. We're able to conduct 29 of these guidance workshops. Now, these workshops, we also get a lot of requests during the reporting periods. The requests were a lot also from the private sector, where we had just started to conduct inspections. And this also, as I've indicated, is meant that people must understand the work that we do and how we perform our functions. The last program would be certification and enforcement. Now, post an inspection, a final inspection report, the inspectorate unit will then make a recommendation for certification of a health establishment. These reports will then go into certification and enforcement, where further evaluation would be made to determine whether that health establishment has met all the criteria and also the processes of inspections have been followed appropriately. Then the unit will either agree, and if they agree, then we issue what we call a compliance certificate. The indicator that we were measuring over the reporting period was that in the event we have to issue a compliance certificate post issuing of a final inspection report, we should do this within a period of 15 days. It is for that reason we had a target of 100%, and we were able to issue 563 reports within 15 days. We have issued all 618, but this was done within the 15-day period. And we also indicate the various provinces where these compliance certificates were issued. It would happen at times that after we've conducted a routine inspection, given a health facility time to remedy the breaches in the norms and standards, go back and conduct a re-inspection and still find out that there has not been much done in relation to correcting or putting corrective measures in order to improve those standards which were failed. When we establish that there is consistent non-compliance, we then take enforcement action. We have an array of enforcement actions that we can take. One such is writing what we call a warning letter to the health establishment. So we then measure that where we have to take enforcement action, we must do this within 10 days after a final inspection report is released. For 23-24, once again, we had a target of 100% because where we must take enforcement action, we wouldn't want to fail in doing so. It is for that reason we're able to reach the target of 45, which was 100%, where a health establishment still did not do well post the re-inspection. I must indicate that once we issue a written warning, health establishments tend to be responsive in terms of remedying whatever or putting corrective measures. It is not the ideal way because we would want health establishments to respond the first time around when we issue a notice of compliance, which details where they need to improve in terms of meeting the standards. There's also other enforcement actions that the office can take, including fines, which is still further down the line. It has not started as yet, or even reporting the person in charge of an institution to either the HOD or even the minister in the Executive Council. Now, the number of health establishments where we were able to publish the reports, we are supposed to indicate that the reports which indicate where we have actually certified the health establishments, and this we do twice a year, and we're able to show that for this year, these are the number of institutions where we took where we issued compliance certificates and where we took enforcement action. Now, the next part, without going into detail, the chairperson has indicated the term of the current board. I must indicate that the board has been quite instrumental in most of the work that we do, and so that they also comply with their fiduciary duties. The board, during the reporting period, reviewed the constitution as well as other documents that relate to their functions. This slide depicts overall our human resource capacity. I have indicated the vacancy rate, but we further give a breakdown of our employees by age. In the main, they fall between the ages of 36 and 54. We do admit that we still have a bit of ground to cover in relation to the gender of our employees. We have 65 males and 34 males and 65 females. And we also indicate the women that are in senior management positions, which are at 47%, 8 out of the 17. We still have a lot to cover in terms of appointing persons that are living with disability as well as young people. I'm going to invite my colleague, Mr. Mapata, who will go through the financial information. Mr. Mapata.
Thank you, Dr. Mdawin. Good afternoon to the Honorable Chair and the Honorable members. I'll take the members through the financial highlights. The slide indicates that there was a slight decrease in terms of the OHSC's revenue, decreasing by 2%. When the National Treasury implemented budget cuts during the course of last year, the OHSC was one of those that were affected by the reductions. So hence we see the slight reduction. However, we just want to indicate that 98% of the OHSC's total revenue was from the national fiscus. Thank you. Next slide. The next slide. Here we want to bring to the attention of the honorable members that once again the OHSC achieved a clean audit as reported by the Auditor General, and we have indicated the slight decrease in terms of the revenue and also the slight reduction in expenditure which resulted from the short-term contract employees who are no longer with the OHSC during the 2023-24 financial year. The CEO has already indicated that. Next slide. And we also had a surplus of 11.9 million as a result of largely commitments from the prior year overlapping into the new financial year. We also raised additional revenue in terms of the interest, and the next slide will indicate what the plans were. The National Treasury approved the retention of the surplus and to continue the short-term employment contract employees as well as assessing the capacity in some of the units. We also wanted to cover the legal costs for the ongoing appeal tribunal matters. Some of them involved the office of the Ombud at the NGOH, and also wanted to cover the prior year commitments on operational expenditure, largely on our ICT systems. Next slide, please. This is the total expenditure per division. We will see that in terms of the breakdown, the support functions made up 43% of total expenditure, and the core functions made up 57% of the total expenditure. And on compensation, we'll see that the large portion of the expenditure, about 79%, was on staff up to level 12, and 21% was on senior management and executive management. This is largely because the volume, most of the volume in terms of employees is in the compliance inspectorate unit. Next slide. And in terms of the staff complement numbers, we noted the typo at the top. The second block should be 2023-24. At the bottom, we will see that the support functions in terms of staff complement made up 29%, and the core functions made up 71% of total staff complement. Next slide. CEO, I will hand over to you to just conclude on the next two slides. Thank you.
Thank you, Mr. Mapata. Honorable Chair and members, as much as we have indicated our performance, which is at 70%, we must indicate, and we should not fail to indicate, that the OHSC does not have adequate funds to enable it to expand and to achieve the objectives of the mandate. We have over time experienced the shortage of human resources, which falls short of what we have to do in terms of expanding the inspections. We, however, looked at various ways and means of realizing efficiencies, such as reconfiguring our processes. I've talked about, conducting back-to-back inspections. We are operating utilizing a centralized model of service delivery where we move from a central office to reach all other provinces. We are aware that this is not the most efficient way for a regulator. We have worked on a decentralized approach. However, at the beginning, this approach would require funds so that we're able to implement, but we are certain that with time, we'll be able to realize savings with decentralization. We've also noticed that the complaints rate overall in the country is increasing, but it is still generally low. And it's important not to fall into the trap of generalizing on our outcomes because we can only conduct the inspections dependent on the funds that we have for that particular year. We've also noticed that with some of the work that we do, health establishments still has to get used to reporting on the early warning system indicators and should understand that these are not meant to punish them, but to improve the entire healthcare system.
Just improve your pace, Dr. Mdaweni, really do. You have gone over 55 minutes.
Thank you, Chair, will do so. We still need to develop more inspection tools in order to cover all the levels of care and the different health establishments and specialties. We still have to also improve and advance our information communication technology environment. And we do also have other, threats and runaway costs, which are related to litigation of inspection findings and the Health Ombuds reports. Chairs, as I conclude, we would like to, our future plans, one of the most important plan is to review the current norms and standards to be more comprehensive and include clinical outcomes and also modify the indicators of risk so that we can have more comprehensive quality health indicators, which will give us a better picture of the performance of the entire healthcare system. And we also want to strengthen the monitoring of compliance with the norms and standards by the health establishments through self-assessment and also the early warning system. And we also want to, through the work that we do, risk profile the health establishments so that we can better advise the healthcare sector. Now, without repeating some of what I've indicated, we believe as the OHSC that our work as a quality assurer to foster and support improvement in the quality care sector is very important. But at this stage, we are starting to see or to realize the benefits of the regulatory work and environment, but there's still a need to improve on the resources and also to improve in making the general public understand the work of the OHSC. Thank you very much, Chair. Thank you, honorable members.
Okay, thank you very much, Dr. Kinoshi. Sorry, I did not recognize that was Dr. Kinoshi on the platform. I could see during the time we were presenting, and I've just been screening here a significant number of board members are here. Thank you very much. You can now assist when members are asking their questions. May I then start recognizing honorable members on this very extensive presentation that was made. I allowed the presentation to go the way it went because this is something relatively new to some of the members, and the functioning of this entity is just like the previous one, Office of the Health Ombud, and now Office of the Health and Compliance. Okay, this time around, Honorable Clerk made sure she's number one. Honorable Clerk, you are number one. You'll be followed by Honorable Dr. Letape. You'll be followed by Honorable Kumalo. Number 3, 4th would be Honorable Senne. Number 5 would be Honorable Dr. Leroux. Anyone that I'm missing? I'm looking at my platform here. Let me just check differently. that the first hand is that of Dr. of Honorable Clark, followed by Dr. Letlape. No. Yes, Dr. Letlape, Kumalo, Sene, and Dr. Leroux is number 4.
Shabangu.
1, 2, 3, 4, 5. Shabangu, you are number 1, 2, 3, 4. Shabangu, you are number 5. Any other member missing? No. 1, 2, 3, 4, 5. Okay, let us start. Honorable Clark.
Thank you, Chairperson. You make me giggle late in the day like this. Anyway, let's go through the questions. Thank you very much for the presentation. It was really a good presentation, gives us a good insight. Given the achievements of the 19% of health facilities inspected, how long will it take you to achieve 100% of your facilities? Of the re-inspections, how many of the facilities achieved compliance after failing the first time round? While it is not part of the presentation, please take me through an inspection and how long does it take on average? How is an on-site inspection done? And I'm asking this because there's facilities that has ideal clinic status, but is in poor conditions, and that it ensures us how they receive it in the first place. And how does hospital self-assessments compare to on-site inspections by the OHSC? And does the OHSC's findings correlate to what the facilities reported? And lastly, what is the status of our public and private facilities? How many of each comply with minimum norms and standards and ideal clinic status? And in your opinion, how long will it be until all public health facilities achieve ideal status? Thank you very much.
Honorable Dr. Letlape.
Thank you for the presentation. My question is, you spoke about 16 appointments out of 20, and you said the moratorium impacted on it. Those were done in 4 months. Am I correct to understand that the 4 that were not filled were also looked at within that 4 months? So the fact that they were not appointed is not because of the moratorium, but because they were not appointed, that you could not go into remedial action to do the appointments because of the moratorium. The second question relates to the issue of internal training. When you were liaising with a tertiary institution, when you do the internal training, do you have the capacity and the competence to do so? And would it be of the same level? Or are you having people that are certified as trainers of trainers from the programs that you've had with the tertiary institution to be able to continue that without compromising on the quality of the training? The one question has been asked about when will all the facilities be inspected? From your timing, your sampling, 50,000, you're doing 3,000, or it'll be greater than 50 years, but I'll be interested in your answer on that. When we talk about a compliance certificate, can you just help me? You know, roadworthy certificates for cars, there'll be 100 things. If one is not done, you fail until you fix that. Is that how it operates? That when you say you have a compliance certificate, so all of you would be at the same level? If not, what would be the different levels of compliance? As a member of the public, when you say this institution is compliant, what does it really mean? Does it mean physical facilities, human resources? You spoke about the fact that when you go to a facility, you'll assess in terms of drainage area, size of the population. On the human resource side, do you avail information as to this size of the institution, this is the need for personnel? With this type of patient overload, you probably even need more people. Is that information available where we could know about what the needs of an institution are, what funded posts are, so that if there's a gap, we know the size of the gap, so that when funded posts are frozen and you still have less funded posts, we can tell on the gap. Because we go on inspections, I mean, we went to a clinic, 280 patients a day, 2 public healthcare practitioners. They cannot cope with that. How do we see that in what you do? And I was interested in, if you could just explain when you say litigation of inspection findings and Health Ombuds report. Can you just unpack that? Because I thought maybe that alludes to the fact that your reports can be used by litigants to litigate against establishments or the state. If that is so, how do we protect the state around those issues? That will be all for now, sir. The other issues, it's in relation to the Ombuds office, synergies, lack of resources. Because if you are complaining using the same IT system, if they become separate, they'll have their own vendor, have their own IT system, have their own board with IT committees. How can we ensure that there's a shared services concept without compromising on the autonomy of the Ombud, so that we can get a greater return for our investments as the people of South Africa and as the state? And you don't have everybody having their own structure, their own HR department, own HR executives, and own board, for that matter. Thank you, Chair.
Honorable Kumalo, thank you.
Thank you very much, Chairperson. Let me also join those who have welcomed the report. Chair, my questions is as follows. The presentation highlights the low reporting rate on the early warning systems. So, Chair, what steps are being taken to encourage and facilitate reporting, and how will this data be used to improve healthcare quality and safety? Secondly, Chair, the presentation also mentions the use of artificial intelligence and data analytics to optimize the inspection process. Then what specific applications, Chairperson, are being explored, and how will these technologies enhance the efficiency and effectiveness of inspections? Those are my 2 questions, Chairperson. Thank you very much.
Okay, Honorable Senne.
Thank you, Chairperson. My first question, how effective are the current enforcement mechanisms in ensuring compliance with norms and standards? Is there a need for stricter penalties or more proactive measures to deter non-compliance? And then my second question, Chair, is what key successes or challenges have been observed in enforcing compliance, particularly in cases where patient care and safety are at risk? Thank you, Chair.
Honorable Dr. Leroux.
Thank you. Thank you for the presentation. Do really welcome the attempt to move the. I've looked through the list of things, and many of those things are tick boxes of documents exist, etc. But I think that can you not hear me?
Maybe
the video. Okay, I'll switch on. Video.
Yes, thank you.
Is that a little bit better?
Much better.
Oh, good. Sorry about that. And so, yes, my very quick comment was, I think I welcome the move towards making more clinical-based assessments available, and that we can really look at the quality of patient care, and that's the first indicator that we look at. The second thing is a question I think that we all would like to understand. I think that we get from your presentation that you are limited by budget, and of course we are in a financially constrained environment, but I think it is useful for us to understand, and I guess it might be a useful exercise to say, for the Office of Health Standards Compliance to do an inspection every 2 or 5 years in every facility that we need to inspect in the country, how much would that cost? How could one expand this going forward? And so I think that it would be a useful exercise to see what would it cost to really kind of roll this out to the whole country. And we need to see as a country whether we can afford that. But I think at the moment it's useful what you're doing, but it is only a small drop in the ocean, unfortunately. And I think as a Department of Health and as a Health Portfolio Committee, we need to kind of think about what is the process of expanding this more widely in the country and what is that going to cost. Thank you very much.
Honorable Shabango, thank you. Honorable Shabango.
Thank you, Chair, and thank you for the report that has been presented. Very comprehensive. Honorable Chair, I wanted to ask this office, as it is there to monitor and to ensure that there is quality healthcare services. As we are marching towards NHI, how is this office strengthening the preparation for implementation of the NHI? And also, what are the plans? Because we know that there will be public, private, and the NHI funds. What are the plans to enhance the information communication so that the information is collaborated between these three entities, the private sector, the public, and the NHI funds? What are the plans that are in place, or maybe what are their plans to ensure that this is happening, to assist, to support the data sharing and collaboration better between the healthcare outcomes? Thanks, Chairperson.
Yeah. Dr. Mdaweni, and the Chairperson, Dr. Kinoshi, I'm asking this question also in the midst of knowing that you have got plethora of challenges with the processes and staffing. But with the inspections going on in the country, are you able to see the impact of what you are doing? Especially some of the colleagues have asked, honorable members, that when you go back to inspect health facility A, are you happy with what you see there? Because it's one thing to inspect and actually guide them to this, that, and the other. Do you find enough time to go back to those facilities before you go to facility B, Y, Z going forward? And maybe with a limited staffing, which one do you prioritize? To say in the country there is X number of facilities, but we'll do X minus 10 and make sure we continuously see this 10 and get them to be up and running until you are satisfied, or you say even with the limited resources, you would want to be all over and then maybe have an impact, which all I'm asking whether you are able to measure the success of your intervention. The second part, when we're listening during the course of the week, we listen that the reports that are coming in from the office of the AG will probably are missing out certain things that you do or that is supposed to happen, because when I asked the AG that these facilities were or were not actually meeting the they were not certified to be provided, was your story is that there will be a certificate of compliance that will say bronze, silver, gold, or platinum. I don't know whether they are still in that space, but that's when we developed it, so that you are saying to a clinic that is getting a certificate of compliance, silver, this is where you are. You missed out because 1, 2, 3, 4, maybe other major things are not in place, but you are doing well on these things. Please improve. And when you come back next year, you give them a gold or platinum. There seemed not to have been any clarity. So it's like there's a tool that you hand over to, or the department hands over to AG, but that tool is either not properly understood or there is something that I missed out in their explanation in that part. But we still do commend you for remaining with the clean audit right through in your performance, and we hope that you continue in that space. You did raise some issues related to proposed decentralization model of operations. I either missed the rationale why you are doing that, or whether you would be able to improve certain things, and what would be the cost benefit of that part. Thank you very much, Dr. Mdaweni. Dr. Kinoshi.
Thank you very much, Chair. I think I would ask Dr. Mdaweni to go first on the questions, and then those that may be remaining, I and colleagues will assist with those as well. But we've taken all the questions down, Chair. Thank you very much. CEO, you can start.
Thank you very much, Chair. Thank you to the questions and comments from honorable members. There's a question asked by a number of the honorable members, which relates to how long will it take us to inspect all the health establishments. If we're to work with the number 50,000, which is what we know, as the office, we need to at least inspect 12,500 health establishments each year. Then in a space of 4 years, we'd have covered almost all of the health establishments. I mentioned the 4 years because in the Act, at least we must inspect a health establishment once in 4 years. Now, with a decentralized model, and also with an increment in the staff complement, it would mean that instead of moving from a central office, we'll have staff located in the various provinces. That will expand our coverage in terms of being able to reach the facilities quicker, and also being within that space of wherever would be. Now comes how many or what type of staff complement do we need to be able to do so? We have revised our organogram. We have looked at various modalities, including subcontracting other levels of workers to be able to assist us with conducting inspections. But then, of course, they will be trained by us. We'll still provide oversight. So we are now at 132 staff complement. The revised organogram, we have 343, which then means that if we can at least have another 181, so we'll then be able to expand, because 12,500 is a lot, and our work is not only limited to doing the inspections, it goes beyond that. The inspections basically are an input, a process towards developing an inspection report, the findings, the recommendations, including the analysis. So that's what we have internally worked out in terms of what do we need to expand the coverage. Now, the self-assessment compared to the inspection findings, it is true, Honorable Clerk, that health establishments tend to give themselves better scores as compared to the inspections that we conduct. But part of our growth and also orientating the healthcare sector, we are going to move into a period where we want to encourage them to conduct the self-assessment and to be truthful and honest to themselves. We want to get to a stage where you give us your self-assessment reports, we randomly pick up any institution that we can go and verify whether your self-assessment actually would align with what we find when we go to a health establishment. And if, let's say, we go there and we find that there is a difference, then we start to look at other mechanisms. But the truth at the moment as we stand is that our inspection findings are not aligned to the self-assessments that are conducted by the health establishments themselves. The outcomes of the inspections in the public and private sector Honorable Clerk, we desist to actually make a direct comparison for the following reasons. We don't have an adequate sample for us to determine and to compare public and private. But what we certainly know is that there are certain things that the private sector would do well on. For example, maybe cleanliness. They will tend to then do well in some of those standards. But what is important, and which is the reason why we want to revise the current norms and standards to include clinical outcomes so that we look beyond some of the process indicators, some of the input indicators, but look at the actual outcomes that come out of an institution, which will form overall part of the health quality indicators. Dr. Klappe asked a question around the moratorium. Now, the moratorium, it came right in the middle of the year. So the 14 out of 20, what it meant, or what I meant is that we did not proceed with appointing staff because of the moratorium. So if we had vacancy rates at the time of the moratorium, then we came to a halt. We only resumed the appointments when the moratorium was lifted. So that's all that was meant. But it is not only because of the moratorium. Honorable Klappe is correct. I mentioned that because of the specialized field of the work of the OHSC, it does become very difficult to source the right skills to occupy a specific position, which takes us longer to fill some of the posts. It then follows on the question you asked again, Honorable Klappe, whether will we not be compromising on the training of inspectors when we do the training in-house. We look at this very carefully and analyze the trainings of our inspectors. Even when we contracted the tertiary institution, the bulk of the information came from us because there's no any other institution that conducts inspections or compliance work in health establishments around the quality and safety of the services. Now, being the only entity that does that, we actually provided most of the material. However, because of the capacity of the tertiary institution, they were able to assist us to refine that. But in the main, the information came from us. So we are going to look at the very same modality of doing this in-house, but there will be certain things that we may still want to outsource. For an example, you know, when it comes to the pagination of information, that will obviously find the requisite service provider to assist us with that content, which we know that is not within the Office of Health Standard Compliance. Will we be able to do so? And also this is part of our, you know, cost containment measures, but let me hasten to mention that it is not meant and it is not going to compromise the quality, which is something that we obviously are worried about and we guard against. Because the very same people that will be conducting this training are the very same people that are actually supposed to undertake the work of the Office of Health Standards Compliance. Now, the other question was the compliance certificates. Are there different levels of compliance? And I think the Honorable Chairperson also asked a question related to this. So when we issue a compliance certificate, there are various gradings of where the health establishment is. We would look at what we call the vital measures. Vital measures means that there are certain things when we go to a health establishment, we must find. If we do not find them, and you happen to have done well in all other standards, we're not going to render you compliant. And these are, if we must find a full emergency trolley, it must be fully stocked with emergency medicine. We must find an oxygen cylinder. It must have oxygen up a particular level. Now, if we do not find that, we know certainly that there's going to be a compromise in the provision of services. You might have done well, or you might actually do well in the other standards, but if you don't have what we consider to be very, very important and critical to save lives, we're going to render you non-compliant and give you a specific time to work on those things. Then you can be fully compliant. So there is what we call it a compliance status framework, which has the various gradings which we look at. I have addressed the issue of the number of posts that we think are needed. Now, the Act does give any individual the right to challenge any finding from the Office of Health Standard Compliance, as well as the reports that are released by the Health Ombud. Now, we have not as yet been challenged around our inspection findings, but because it is in the Act, it is true that this may happen at any given time, and it's not only an inspection finding, it can be any other work that we do. And usually we have no way of knowing which of these reports, which of these findings are going to be challenged, which is why we then say it is a threat and it is a cause that, you know, we can only benchmark, but will never be certain and be exact in terms of how much we actually need in relation to that. I'm going to request my colleagues to deal with the question on re-inspections, the inspection and the inspection process. Honorable Khumalo asked about the low rate of reporting on the early warning systems and what steps are taken. I will start off by saying that we always encourage the provinces, when we provide feedback on the early warning system, the importance of reporting. In the event we do not, there are instances where when we do not get joy, when we interact with the various health establishments, where we actually even write to the head of department and inform the head of department of some of the institutions that maybe did not submit annual returns. But with the early warning system, because here we are reporting on indicators of risk, it's continuous education and raising awareness and making the health system or the healthcare system understand why it's important to report on this, because we want to prevent recurrence of these critical issues that happen at health establishment that compromises the quality of care. Again, Honorable Khumalo asked about the optimization of our processes, particularly inspections. We have developed a concept on smart inspections. What we actually mean is that along the whole array of the work that we do, there's a lot that can be automated, including considering doing virtual inspections. However, these must be informed, and also there are a lot of things that we have to look into before we do that. We do have best practices in other countries, other regulators that are in the same field as us, where virtual inspections are conducted, and also the optimization through various gadgets and technology, so that we actually enhance the speed with which we conduct these inspections, and most importantly, release the report timelessly, because the most important thing is that there must be this report that the health establishment must then respond to or act on. And we believe that this will certainly improve the work that we do. Dr. Leroux commented about the limitations around the budget, and also to understand the inspections over the 5 years and what would we cover. I have in a way responded to this by saying each and every 4th year, we must go back to the very same institution and inspect it, or they must then write to us and inform us that they are due for an inspection. And I have indicated the numbers that would require over time. Honorable Seme asked about the effectiveness of the enforcement action. To date, the written warnings have actually made facilities to respond, because now they know that we are enforcing. We have other enforcement actions, like I've indicated, we can ask them to pay fines, but that is a process that will follow, because it has to go up until the National Health Council and gazetting. We can report to the head of department to take action if we feel that there is no attention paid to the findings that we have given. But again, we have also started a process of engaging the healthcare sector, the provinces, on the enforcement action issues. What we do is that once we have the notices of compliance from a particular province, we then engage them on what we call pre-enforcement workshops, so that we explain to them and we make them understand the importance of actually dealing and correcting or remedy the breaches in the norms and standards. A question asked by Honorable Shabangu, how our preparedness for the NHI. We have a program that we have started internally, really, which is looking at our state of readiness with for the implementation of the National Health Insurance Act. We are in constant contact with the NHI unit. This will include advancing and enhancing our IT system to be interoperable with the NHI, such that once we have conducted an inspection, the report is available on their side real time. And also we are looking at an entire reconfiguration process, and also looking at the consultations that they will have with the Office of Health Standard Compliance prior to accrediting a health establishment. So there is a whole program of action that we have put in place in order to address and to be ready with the NHI and to better collaborate. The Honorable Chair asked a question about the impact of our work. We believe when we look at where we started as the OHSC, we can confidently say we are indeed starting to see that there is impact in the work that we do. We started at an era where there was absolutely no understanding of why the services or the healthcare services should be regulated, where there was actually even resistance in some quarters. But the healthcare sector is now fully on board and understand why the quality of services must be regulated. And it's only fair to also mention that there is eagerness to actually comply with the norms and standards. But we still have a long way to go in actually, even in those institutions where we have conducted the re-inspection, some do improve, others do regress. So there's still a lot that needs to be done, but some of these activities are actually then transferred to the quality improvement processes in provinces, and also working with the National Department of Health, the National Quality Improvement Program, because these findings, we share them also with NDOH, with provinces, so that they develop the quality improvement plans. The chair also asked whether do we go to the same institution or and take those institutions along up until a certain level where we're comfortable that they are compliant. Honorable Chair, we try to expose the healthcare sector to our regulatory work. We don't necessarily go to the same institution. We try to go to those that we did not inspect the previous year. The ones that we revisit are the ones that we know that these ones we need to re-inspect because they failed on some of the norms and standards. We will certainly look at the framework that was discussed with AXA, but just to indicate that our compliance status framework is also graded. But we will certainly follow up in terms of what the tool that was discussed. Now, the cost benefit of a decentralized model. In the initial stages, it will require fund injection to establish hubs in various provinces where we'll be able to do the regulatory work in quality assurance. Now, the biggest advantage is obviously access of the OHSC to all the health establishments that are around, and also so that we can be able to engage and monitor at a closer level. This will definitely expand the footprint of our inspectorate functions as well as a coverage. I'm going to request my colleagues from inspections to deal with the re-inspections, the figures in terms of those that were found to be compliant or non-compliant post the re-inspection, and also to describe an inspection process on site, what happens. That was from Honorable Clark. I'll also request the CFO to briefly discuss the overall cost of an inspection, which at some point we also had costed. And if there is a question that I've left over, colleagues, if they could kindly assist as well. Thank you. Over to the inspectorate team, followed by the CFO. Thank you, Chair.
Inspectorate team.
May I ask Mr. Piri or Mr. Kumalo?
Good afternoon, Chair and members and colleagues. CEO Mr. Piri is sitting in the where he can't unmute. I think he's in the public platform. If he can be allowed to come through, please, CEO. Maybe whilst he's coming through, there was a question that came from member Kumalo about what the action that is being taken, or what are we doing with the low reporting rate on the EWS. We can say we do. I'm Dr. Matabo Matebula, the Chief Operations Officer. We have engagement with the head offices of the private health groups and also the departments, provincial departments, and ever since we have started those engagements to encourage and to alert, in addition to alert the health establishments of that requirement by the OHSC, we are starting to see some improvement in that regard, but we believe it can be better. If we can request that Mr. Piri can be allowed to come through to respond to the compliance inspectorate questions. Thank you, Chair.
Thank you.
Okay, thank you. It's just Dr. Kenoshi. Whilst Mr. Piri is coming, if I may make one comment on the question posed by Honorable Chair, the one about the outcome of inspections, the certification process. As you gave examples of bronze, silver, gold, and then the top one being platinum. Coincidentally, this was one of the points of discussion in a prioritization and strategy workshop held by the board with the OHSC executive in the last 2 weeks. And it came out of the fact that in the NHI Act, they talk about accreditation, but they also talk about conditional accreditation. That is for people who are not there yet. They have not passed the certification, but they are almost there. So they've made room for in the Act for conditional accreditation. So that would require that, the NHI depends on the OHSC certifying these institutions. So it would mean that the OHSC would have to develop a new inspection strategy and certification strategy, and that would allow grading of the certifications. And this is what the OHSC is busy about. And although we didn't call them a bronze, silver, conditional, gold and platinum being the top one, but it will be something similar that would allow NHI fund to do conditional. Maybe we would say gold. Those who are gold, who are almost there, and platinum would be sorry, gold would be for additional certification, and platinum would be the certification itself. So there is a process to address exactly what you are saying. We're saying this because we know that in the first 5 years of implementation of the NHI, most institutions, especially unfortunately public health establishments and healthcare providers, would not reach full certification on the first inspection. And that would cause a problem. So we would need to allow for those who are almost there and give them an opportunity and a timelines to achieve this thing whilst they are able to contract with the NHI fund. Thank you, CEO. I think if your inspection team is ready, they can go ahead.
Thank you, Chair. I think I've heard Mr. Puri struggling with his mic. So what happened? Oh, you are in. Okay.
Yeah. Thanks, CEO. Thanks, Dr. Kinoshi, honorable members. Just I was sitting in a wrong platform. We had 2 links that were sent to us. I will respond then to the question. I think it was asked by Honorable Clark in terms of taking them through the inspection process. How long does it take to inspect a facility and what happens? Now, our process is defined or categorized according to the levels of care of the facilities that we inspect in terms of the length of the inspections that we will take in conducting inspection. For instance, in a clinic, what we say it's functional areas, which are 4, and a functional area is where the services actually is taking place. So we will divide the clinic therefore into 4 functional area, which will be the clinic manager. In that section of the clinic, then we are looking at mostly the inputs that needs to facilitate then service provision. And then we have what we call then clinical services. That's where all the clinical services are taking place. Then we will assess all those areas where then clinical services are taking place. And then the third one then would be then the provision of medication or its availability, where we would then assess the medicine room, pharmacy, dispensary in that way. And then lastly, then in the clinic, then you will look at facilities and infrastructure, where you are looking at the maintenance issues related to the facility. Now, to conduct inspection at that level of a clinic, only a day or 6 hours to complete that work. Then when you go to community health centers, because now what we call functional areas becomes more, you would then have more divisions where you will, before that I've spoken about, then you will have maternity sections that you have to also look at the rehabilitation sections of the area that has to come on the dental services, etc., depending on that community health center. Now, when you inspect then the clinic, then you would then need inspectors to complete that work in a day. But when you go to community health center, then you need 5 members of the same team. Our inspection teams are made up of a team leader and 4 inspectors, which makes them to 5. Now, when it comes then to the hospital, then it will take us then 3 days, sometimes depending, then it would be 4 days for the entire team, because now the functional areas that we need to be looking at are far more. If you look at a district a hospital, the normal district then would have up to 35 functional areas that you would have to assess. Therefore, then it takes us 3 days then to complete that. And then we use different methodologies then to conduct these inspections, where we would be looking at reviewing a document, which is the input of service delivery. Then we will review quite a lot of documents that needs to be in place, policies, SOPs, guidelines, minutes of meeting, etc., that we would have to look at. That's one of the methodologies. Then the others, then we would be interviewing then the staff, because then we want to triangulate if they are informed of other things and processes that they are supposed to be knowing, working in a particular setup. And then the others then is where we would use observation. Then we using the sense of seeing, then checking and assessing throughout the facility, cleanliness, etc., availability of other materials. CEO was alluding to emergency trolleys. Then we would observe and check if they have those systems in place. And lastly, we would also then interview patient and not last, but we would interview patients also, because they are the recipients of these healthcare services, and we would want to hear from them. And then we would also then review the patient records and assess if the clinicians and everybody working on this records are recording and recording the care that is provided to the patient. I think that's in a nutshell in terms of the process then that we would follow in that. And we would then use the tablet to collect this data, and then it has processes of quality assuring. We would start there on the site, where the team leader then will check and validate this data. Then we come to the office. Then also then the inter-team validation, where we exchange then our findings with other teams. Then they validate each team's work before we produce a report to regard then to the number of facilities that are compliant after we have inspected it. Unfortunately, 23-24 finalizing analysis of that data. We do not have it, and I'm sure, but we can provide it. I'm sure it will be available. But just to give a glimpse then of the that comes in the rate of compliance. If you look at then 2023 financial year, where we re-inspected 139 facilities, only 66 were able to comply, which makes 47% of that. And it obviously then says that the remaining percentage, which is 53, then from our side, then we would be recommending those facilities to enforcement. Like there was a question relating to enforcement. That's where then we would be referring the matters then to the enforcement unit then to work with these facilities until they are ready then to comply. CEO, I guess those are the two questions. I don't know if I'm leaving anything behind. Thank you.
Can you get the CFO now?
Thank you, Honorable Chair. In terms of the inspection cost, there's no standard cost of an inspection for the following reasons. One is that the location of the facility will determine the cost for that inspection. For example, the inspection in the Western Cape will be more expensive than an inspection in Gauteng, and an inspection in Limpopo will be more expensive than the one in Gauteng. So the location of the facility plays a role in terms of the cost. The second factor is the type of facility that is being inspected. A clinic will normally take a day, but a hospital will normally take 5 days. So the duration of the inspection period also contributes to the cost of an inspection. So on average, the inspection cost of a hospital can vary from anything between 70,000 to about 130,000 in a week, also depending on the number of inspectors on that during that inspection week. And the same logic will apply to other categories of facilities such as the clinic, the CHS, and the GPs, etc., etc. So the cost is not a standard one, but it varies from province to province and also by type of facility that is being inspected. Thank you, Chair.
Any other contributions, Chair, Dr. Kinoshi or Dr. Mdaweni, or you are done with the presentations and responses?
Thank you, Honorable Chair. Oh, please go ahead, Chair.
Yeah, Chair, I believe we are done with the questions, unless if members still have or feel we haven't. There was just one aspect from Dr. Letlape about how, especially regarding our inspection and our inspection reports, how do we ensure that or protect the state from litigation, arising out of the reports that we issue for health establishments and healthcare providers. And I think maybe one could answer the Chair by saying that we ensure that we inspect compliance according to standards that have been promulgated by the Minister. So the standards are developed in the OHSC, but then they're taken to the National Department of Health for the Minister to look at. So those standards are signed off by the Minister, and the tools to inspect the health establishments are also discussed first of all with the health establishments and the healthcare providers, and they are trained on them, and then we ensure that they are also agreed by everyone, including the National Department of Health. So the report, just to ensure that the reports are accepted by everyone and that there's as little litigation coming out of there as possible. But also the OHSC has got a good team of legally trained of lawyers. But if there is a need, and the lawyers support both the OHSC and the Office of the Ombud, and if there's a need, there is budget we put aside budget to outsource any expertise, especially at council level, and even to the extent that if the matter has to go to a ministerial tribunal, which has happened, we are able to support and defend the state. Thanks, Chair. CEO, you can go ahead if there's anything you want to add.
No, thank you very much, Chair. We are covered. I think perhaps the one question was on how can we implement a shared service concept without compromising the independence of the Office of Health Ombud. I think both offices got each independence very seriously. Indeed, the shared services would be around all the supportive functions of any office to function effectively. But when it comes to the actual work and the activities, those are quite separate. And so far, we have been able to maintain the independence of both offices without compromising the other. I will give a typical example. Both offices have looked at the Helen Joseph incident, and the Office of the Health Ombud conducted its own investigation. We also use our tools to conduct an inspection. So at the time that we release the findings, they will be from the two officers, but would have done our function within our jurisdiction, and also the Health Ombud would have done the same. Thank you.
No, we'd like to express our thanks to you, Dr. Kinoshi, the chairperson of the board, and the entire board members who I've seen logged into this meeting, together with the CEO, Dr. Mdaweni, and your team, all the executives that have supported you with the presentation and the responses. We would then want to release you, and thank you very much for all that. As you exit, may I just thank the honorable members that since yesterday you started in the morning listening to the Financial and Fiscal Commission, the AG, the South African Medical Research Council, and Mines and Workers' Compensation. This morning we woke up to Council for Medical Schemes, SAHPRA, and just before Office of the Health and Compliance, we were listening to the Office of the Health Ombuds. I hope that, honorable members, you will have your questions available and ready after the presentation, which has been sent to us, the presentation of the minister, and therefore we will take it from there. And we have a meeting with the minister just to make an announcement. Because of other pressures over the Friday, we are meeting with the ministry tomorrow at 6 o'clock. After the president has actually answered questions in the National Assembly. We have agreed to allow members to log into their car, get into their cars, traveling, get into their offices. We start the meeting at 6 tomorrow. Hopefully should be wrapped up by 9. The members will notice that the NHLS did not make a presentation. They wrote to Parliament requesting that their report be postponed, because you probably remember there was a cybersecurity matter in the NHLS, and therefore it affected their preparations to submit. Parliament has since granted them the extension to submit, and therefore we might look into their report some other time later. But all these preparations for the budget review and the reports that we have actually been listening to is to prepare ourselves for our meetings next week. So for now, honorable members, thank you very much. After the sitting tomorrow, please, we will await the login details for another virtual meeting with the Department of Health. And remember to have these clarity-seeking questions and comments to engage the department on that one also. And thank you very much. Have a good evening.
Good evening.
Thank you very much, Chair. Thank you.
Thank you, Chair. Thank you, members.
Thank you, Chair. Good evening.
Thank you, Chair. Good night.
Yeah.
Recording stopped.
Thank you.